Can you hear me okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Sorry. Perfect. Okay. Yeah.
Okay, thank you. Thank you, everyone. Ooh. Thank you, everyone. I'd ask you to take your seats if you can. Now, we did have an Indigenous elder that was here to welcome us to country, Kumli, who I think has gone outside. Here she is. Okay. But I'd like to welcome you here, but I will defer to Kumli. Would you like to come up to actually welcome? Sorry, come up and wherever you like, but probably up here to the microphone. Yeah, okay. Thank you.
Where is it?
Right. It should be all right.
What everyone? What it means hello, like good day, in the local language Arada. Alarit Nachina, Kumlik Warai, a young Aranda, I'm a red woman, Brendan Nicola Magaga. I grew up here and grew up at Bush as well. And my homeland, my relation to the land stretches right across here, right up to the northeast, anyway, because of our connection to our country through song lines, stories and songs, and dancing that is still very much alive today. Wala yung apa jaga, aran tadi ko jaga pemrano na kanona, aran tadi la pemrano na kurang jala pajuarga, Gut Centre na kurang jala. I've come here to welcome you all. You have come many miles from all directions of Australia for this special meeting. Very important meeting to the Gut Centre meeting, the forum you have here. It's very interesting to know because anyway, on part of our elders, past, present, and future, yung angkama, jangan rumah baru kuling ma pula pemenang di Kuala Lumpur, and my families have danced and sang and had their meetings, big gathering like this, to share and grow the next leaders to carry on their leadership in our cultural and as leaders from each area that come and gather here to sing and dance and pass our knowledge to the next generation of elders or leaders. So it's a very important site around Alice Springs here. Many sacred sites and important sites around Marambardra, Alice Springs, and right through the Northern Territory here, and right up to the Darwin. They have many other tribal people that still carry on and still practice their culture and law and order as we do here. The law and order is, we live in both cultures, and we wear the two hats, not this one. This is my beanie. Still on. And we have been through education. We've been educated enough to understand how health education is very important for all of us, all our people. And I have been involved in Menzies Health. We've done an app and did a language, translated into language, and we've got an app there that we can go around to how people go around and talk about Hep B. What's it about? How does it go? And there's very many there are very many means diseases in our bodies, and It's there. It's still, some are asleep. Some can be woken up through research. And some can be detected early, some can't, or depending on how far our health system reaches out to our people out in remote areas as well. And education is very important to educate our people about any type of issues in health. I've had health issues, but it was mainly because I lived out bush. I was a station kid and I had very bad ears. I had ear operations. But in the other side, or this side, I woke up in the middle of it. Somebody didn't knock me out. And I woke up and said, "Oh, are you God or are you angels?" Next minute, bang. And I was back in bed and I was telling them, the surgeon, I saw God and angels last night. But I was only young from our bush, and it's a very alienated place. It's city hospitals for us, for our people, for our kids. And I still remember that. And I was put in the recovery room, and there was lots of other bodies there. And I looked around, I was strapped, couldn't run away, and I started screaming. I thought they must have thought I was dead, and they put me there with dead people. But it was a recovery room. There was a lot of other people in the recovery room, and I'm going to tell you, I screamed. "Oh, don't be silly. It's only, it's recovery." But I didn't know what recovery was at that time. And it's a journey too. We learn as we grow older about situations, about what to expect. Even in bowel cancer, we get all these packages that we receive in the mail. I've got one. I'll get on with it. The bowel cancer, got to send it back. And I explained to my mob, if you get envelope like bowel cancer, that doesn't mean you got cancer. We got to get specimens like when we go to the clinic, we give wee samples. So the doctor wanted to know what's in our wee. But this one, we got to, get the other stuff. Oh, how? And they said, "Oh, true." Yeah. So I explain it, and even to the people that's got something wrong with their heart. Because I had angiogram at a very early age, and I went to the Adelaide Hospital. Where was I? Somewhere there. One of those big hospitals. And they put me in, they put the angiogram in. And they said, "What are you doing?" "We're pushing this little thing up there so you can see your heart." And then the doctor said, "Do you want to be knocked out?" And I said, "What for?" "Oh, some people like to sleep through it." And I said, "No, I want to see my heart, This is something very interesting." But I was frightened too at the same time, being a young person. And I see this little thing going in there, there was this thing going, bang, bang, bang. And I said, "What's that?" And the doctor said, "Oh, that's your heart ticking, love." "Oh, true." "Oh, I can tell you, I fell in love with my heart. I fell in love with myself. And now I know how to love myself." Great. It's scientifically and all these, we learn a lot from that. Then I go back and tell other families that are scared to go and see doctors if they've been diagnosed with anything. I talk to them and let them know it's not that bad, because now they can see everything in our chircha, in our body. So I'm sort of out there telling everybody, translating and interpreting as we talk about people, families, talk about kidney, tabarka, tagada, aralja, and all those organs inside us. It's very interesting. Just like to let you know, and I hope you enjoy your time here and your days. And I know it's a bit cold. We're running around looking like Inuits, and you see these city mobs, you see them run around in little shorts. And, the tinglers running around. And we look at them when we're driving past, and we go, "Ooh, are we cold?" Well, that's city mob. We just call them city mob. If you see a city mob run around with shorts and singlet, that's city mob. Anyway, enjoy. I like to just sit in and listen to this exciting, stuff on the thing. But I'd like to know more. Kala? Kala means okay? Now you got to say, Oraka Arichinanga. Oraka Arichinanga. The Oraka Arichinanga, that means see you later. But if I won't see you after this. But if you're a local doctors from here, a hospital, I will say, Arichinanga. Arichinanga means catch up later, see you later. Enjoy your time here too. Enjoy Alice Springs. Kala? Thank you so much.
Thank you, Kumli. I think you've given one or two of our talks already describing fecal occult blood testing, so thank you very much. Really appreciate that. I would like to welcome you all to the third very special Gut Centre. It's special for me because I've got a particular interest in cancer, and the theme for the next 2 days of evening lectures that you're going to be exposed to is cancer. Today, colorectal cancer. And I think we're having a colorectal cancer dinner, as described here. And then tomorrow we're having hepatocellular carcinoma. I particularly want to thank you all for joining us in person, and I also want to thank the many people that are online. For those online, if you have questions and you want to post them, please do. We have someone that's actually monitoring the question banner or the chat, and we can address your questions as we go. The way we'll do this first session is to have a few presentations. Hopefully we can get through them reasonably quickly, and then I'll invite the speakers up so that we can have a general panel discussion, open it up to general questions. If there's burning questions after each talk, maybe we can have one or two. I also would like to thank, can we put the main slide up? Thank you. Our sponsors, who without this, this wouldn't really go ahead. So the main people here who have helped us actually achieve this over the years, and I would say recurrently over the years, have been those listed on the slide at the moment, particularly Olympus, Boston Scientific, Pfizer, GSK and CSL as well. So please join me in thanking them for actually sponsoring this event. I also would like to importantly thank our partners in this, and it's the Gastro Society has actually been the main front runner in terms of the organisation, but we've got great representation from GENCA, our strong collaborators and partners within the nursing space, as well as NT Health and particularly Alice Springs Hospital. And so please thanks. So without further ado, I'll open the meeting by inviting Matthew Lawson up. Matthew's the Acting General Manager for Alice Springs Hospital, and it gives me great pleasure to actually have him here as one of the strong collaborators in this initiative that we've been through for the last 3 years. So Matthew, please.
Thanks, Alex. Thank you. Just getting myself organised. So thank you again, and good evening, everybody. Welcome to the GESA Gastrointestinal and Liver Education Evening here in the epicentre of Australia. The very beautiful, sometimes chilly, Alice Springs. My name is Matt Lawson. Yes, I'm the General Manager acting for Alice Springs Hospital, and it is my privilege to welcome you both in person and online to this evening's event. Before we begin, I too would like to acknowledge the traditional custodians of this land on which we meet, the Arenda people, and pay my respects to their elders, past and present. This land holds deep knowledge, culture, and stories that extend far beyond medical journals and textbooks, and it's a privilege to live and work here. As you will recognise and appreciate, building knowledge and improving services requires immersion, being focused, and surrounding yourself with like-minded people. And while you're here in Alice Springs, you should do the same with the land and the people. Take a break if you can. Go for a walk to Telegraph Station, drive to Simpson Gap, see the rock formations. Think about how you can connect with this land. When was the last time you stopped and thought about, what is my story? Tonight we're gathering not just to talk about advances in gut and liver disease, but also reflect on how we can be better, more inclusive, and more effective in serving the communities around us, especially the Indigenous communities who face disproportionately high rates of gastrointestinal disease and hospitalisations. What GESA and the Gut Centre program is about is providing that opportunity for change, to improve patient care, building solutions to complex problems, and being a leader in new models of care. Because in regional settings like Central Australia, where access to healthcare can sometimes be as patchy as phone reception in radiology, that need is even greater. We're lucky tonight to be joined by clinicians, specialists, and community members who are passionate about Indigenous health. Some of you have even had the opportunity to visit our remote clinics, building trust, navigating language and cultural barriers, and often doing more with less. So tonight, let's not forget the stories. Behind every scan, test, and scope is a person, a family, a community. And behind every successful treatment is a collaboration that started with committed, caring, and like-minded people who wanted to make a difference. Thank you all for being here, for the work you do and the commitment to bring GESA to Central Australia and the Alice Springs Hospital. We truly appreciate the difference you are making to a more knowledgeable clinical workforce and more equitable, accessible and targeted gastrointestinal disease management service. When I was talking to my wife last night about giving this address, I asked, what could I possibly offer a room full of educated, knowledgeable and passionate people? And she said, they're GI, just keep it moving, just keep moving. It's GI, you'll be right. And with that, thank you, honestly. Be inspired by this amazing land. Think about your story and how together we can make a difference. Have a great night. Thank you. Thank you.
Thanks, Matthew, for those lovely words, actually. I'll first invite our first speaker because we need to crack on. Kirsty Campbell is the clinical lead in gastroenterology at the Royal Darwin Hospital and very passionate about Indigenous and rural health. She's a current board member of the Gastro Society of Australia and has been very active in that space. So, Kirsty, over to you.
Thanks, Alex. Thanks, Matt, and thanks, Auntie, for that wonderful introduction and welcome. I'm going to be talking to you tonight about colorectal cancer screening, particularly from the perspective of the Northern Territory and some of the challenges that we face. But just starting with a little bit of an overview with regards to colorectal cancer in Australia. So unfortunately, it's the second leading cause of cancer-related mortality that we face here in Australia, behind lung cancer, but is the fourth most commonly diagnosed cancer behind breast, prostate and lung, meaning that often it's diagnosed late and morbidity and mortality is high. National Bowel Cancer Screening Program was launched in 2006 and offers 2 yearly fecal occult blood tests for individuals aged between 50 and 74 at the moment. It has recently expanded that and it's now opt-in for those between 45 and 50. Despite being universally available to this cohort, participation rates are suboptimal and hover between 40 and 45%, with us seeing a slight dip in recent years for a variety of reasons. However, what we do know about bowel cancer is that early detection via national bowel cancer screening or other modalities reduces mortality significantly by diagnostic downstaging. Despite national averages sitting at 40 to 45% for screening, in the Northern Territory we know that it's significantly lower than that, and data estimates this to be at about 30%. This is due to a number of reasons. So firstly, we've got this extensive geographical remoteness for a relatively small population size. This means that we've got significant reductions in healthcare access in our rural, remote and very remote areas. We recently learnt that in both Gove and Katherine, the 2 mainstream GP practices are closing, meaning that even our patients in regional centres have significant access issues to baseline health investigations. There's also limitations with the test kit and these being degraded in extremes of temperature, and they're also not delivered to people who live in regional and remote communities where they have to sit potentially in a post box for a number of days. Auntie spoke about the impacts of the First Nations population participating in this screening. If any of you have seen the test kit, it's extensively in written English, so many of our patients are not fluent in written English and predominantly speak, speak a number of languages, and this also impacts their ability to participate. And then we've got cultural challenges such as discussing bowel habits, guna, kaka, jaja, especially with people of a different gender. So that can be quite taboo as well. Once we can even have the conversation, it's very difficult also to get patients to participate in that screening test due to overcrowding, sanitation issues and access to safe and clean toileting. Speaking with my GP colleagues who are rural medical practitioners and serve these populations, they've essentially told me that unless we can get a stool sample off a patient at the time of that encounter, it's essentially not going to be done, unfortunately, for a variety of these reasons. And so this further diminishes participation. However, it has been really interesting to note from their perspective that the discussions around colonoscopy have spread across the community, and the patients are much less reluctant to proceed with colonoscopic investigations than maybe they were 5 or 10 years ago, which is definitely fantastic from a grassroots educational perspective. In order to try to combat some of these factors, National Bowel Cancer Screening Program did introduce a pilot in a few remote Aboriginal communities in the Northern Territory a couple of years ago, whereby they sent the test kits directly to the clinics and allowed the GPs, remote area nurses and Aboriginal health practitioners to disseminate the kits to patients, and it also facilitated those kind of language barriers in terms of filling in the paperwork and things like that, but still it didn't significantly increase the rates of uptake, unfortunately. When we look at incidence and prevalence of colorectal cancer, we know that nationally we're sitting at about 65 cases per 100,000, but in the NT this is significantly lower at about 45. Doesn't mean that we don't have bowel cancer, it's just I truly believe that we're underdiagnosing and therefore underreporting, which is a real shame, and hopefully we can see an improvement in these statistics with improved workforce and both specialist, general practice, nursing and health practitioners so that we can get patients the care that they need earlier. Looking then at mortality, national mortality sits at around 20 cases per 100,000, with it being slightly high in the male population compared with the female population. And this, we see similar rates within the Northern Territory, but we do have a much bigger age bracket, much bigger range bracket, with there being about 9 per 100,000 deaths in the First Nations females, rising to about 22 in the non-First Nations males, and both First Nations males and non-First Nations females sitting just below the 20 mark. Unfortunately, we do see those significantly higher mortality rates amongst our First Nations populations, with mortality rates being about 1.6 to 1.7 times higher than non-First Nations counterparts, and that's simply due to the barriers that they need to face in order to be diagnosed and therefore access appropriate treatment. And this includes delayed diagnosis, increased staging, and then limited oncologic services. This means that in order to have surgery and access oncologic care, patients need to be displaced from community, country and family, so often that can be challenging for them as well as again those cultural and linguistic barriers, and also cultural views on healthcare can sometimes be different as well. Looking specifically at early onset bowel cancer, this is defined as colorectal cancer that occurs in those under the age of 50 years. And unfortunately, Australia has got the unenviable title as having the highest rates in the world, sitting at about 16 per 100,000, and this is increasing significantly year on year. Unfortunately, those born in roughly my cohort have a 3 times increased risk when compared with our parents' generation, which is quite alarming. It represents the leading cause of cancer mortality in those aged between 25 and 45 overall, and in the men, with it being second in women to breast cancer. Unfortunately, because of our small population size, we don't have NT-specific data on early onset colorectal cancer. However, I do see this as being a good research opportunity, given that the data already exists within the cancer registries. We would just need to pull that forward. We've touched quite a lot on the First Nations health disparities that exist. We do know that there's lower participation rates in National Bowel Cancer Screening Program, and this results in increased mortality and lower overall survival, unfortunately, with a number of factors contributing to this. How can we optimise this? So I think in the first instance, we need to have culturally appropriate education materials that can be delivered to patients on country, in community, ideally in language, so that they feel that they're in a safe space to receive this information and potentially open up and talk about a topic that's perceived to be taboo. We need to involve the local healthcare staff, the Aboriginal health practitioners, remote area nurses and the GPs that are integrated into these communities and have built that trust and relationship over a longer period of time. And we need to consider other ways that we can screen this population, and maybe if fecal occult blood test is not the answer, then maybe we need to offer high quality colonoscopy as a diagnostic baseline in this population. A couple of years ago, we decided to look specifically at our local data because anecdotally, we felt that maybe we weren't detecting polyps as much in our Indigenous cohort as our non-Indigenous cohort, and we weren't sure whether that was because they didn't have polyps and maybe they had other pathologies as well, or whether it was just, I guess, a perception or a bias that we had. So there was established data with regards to the colorectal cancer rates between First Nations and non-First Nations patients, but there was very limited data with regards to polyp detection. So we actually looked at all index colonoscopies performed in the Northern Territory in the year 2017, which was slightly less than 900 procedures. What was really interesting, and I guess the take-home message, was that there was no difference in the polyp detection rate or the polyp histology between our First Nations and our non-First Nations counterparts, which means that we're looking, we're finding, and there's no difference, which is great. Also importantly for us was rurality status, and does this impact patient outcomes? And fortunately, there was no difference First Nation status and rurality did not impact our polyp detection rate. The thing that really was quite interesting though was the indication for which these patients had their colonoscopies. Our First Nations patients were far more likely to have colonoscopies for iron deficiency and anemia, which can be multifactorial, driven by chronic disease, food security and accessibility, compared with our non-First Nations patients, and also less likely to be referred for a positive fecal occult blood test. So it was good to see the data, but that take-home message was unsurprising to us as clinicians. So in summary, we know that the Northern Territory has lower screening rates and perceived incidence, but higher mortality due to underdiagnosis and underreporting, and this is especially true amongst our First Nations populations. And this is driven by a variety of reasons, but ultimately geographical, cultural and health economic factors play a big part in this. So how can we move forward and try to optimise this? So we definitely need targeted interventions to try and boost the screening uptake locally, whether that be through fecal occult blood test or another modality that hopefully we'll hear about tonight. We need to have culturally sensitive and appropriate education materials so that we can get this message out about bowel cancer and screening, break down those taboos and enable patients to feel comfortable and motivated to progress in this journey. We also need some investment locally with diagnostic and treatment infrastructure, both human resources and non-human resources, so that we can get these patients moving along this journey as quickly as we possibly can. And we also need more research to address some of the root cause disparities so that we can be a little bit more targeted in our strategies. Thanks very much. I'm happy to field a couple of questions from the audience or online. We've got a roving mic, will come around.
Thank you so much. My question was about the pilot program sending the kits out to remote clinics. Are there results yet in terms of uptake, or how successful was it?
I don't think it was particularly successful. I don't have the statistics. I think it was a little bit kind of kiboshed by COVID, like a lot of other things, but I would have to liaise with my GP colleagues and colleagues at National Bowel Cancer Screening Program as to whether it was effective. The GP certainly said it enabled that discussion to take place, and if patients had indications for proceeding to a colonoscopy, they were certainly much more likely to just proceed straight to colonoscopy rather than trying to obtain the stool sample as kind of a screening test. So if they had iron deficiency or anemia or any kind of altered bowel habit, they were more likely to go straight to scope. And that's because the GPs felt that enough patients had had colonoscopies to be able to share that information with the rest of their community about that kind of bowel prep and colonoscopy journey, which I think is really important and making headroads into trying to narrow the gap that exists. We've got some questions up the front.
Hello, my name's Paula. I'm one of those remote GPs. I look after 3 different remote communities here in Central Australia and work for them. I just wanted to share a couple of anecdotes. I've had one male storm into the clinic absolutely furious that a big envelope with the words bowel screening arrived at his workplace, which very much embarrassed him. He thought it was the clinic's fault, so we had to explain it didn't come from us. He did achieve his bowel screening after we talked everything through. Just last week, I had a lady who told me that she had a big envelope at her house. She was too ashamed to bring it to me in clinic, and I've known this lady for 3 years, so we get along very well. She asked me what time I'd be leaving the community and would be driving past her house, and could I pop in and just explain it to her. So that was just some anecdotes of how it can be received in community. Mainly, I just want to ask, the CST program for screening works very well in community. The Western pathology lab that we use here communicates with the national screening data. All of the results go through there. Nothing has to be sent through the post office. It's all sent through the clinics. The clinics have care plans which make us update results, and then we go searching for people when there's abnormal results. I'm just wondering, given that we do send, and people do achieve FOBs through Westerns, but I'm assuming they don't talk to the national screening program and get that data through. So it's not that the local people I work for are necessarily against doing the poo test.
Correct.
Once it's explained to them, and since it's in our control, I've had knocks on the back door with just a brown bag handed through in clinic, but there's a good understanding, and it's left in the hands of the clinic, which is the people that they trust.
Correct.
And they also know, obviously with the CST program, we get sort of immediate electronic notification of any abnormal results, and we have processes in place so that that's not missed for follow-ups. It's just interesting to me that the national bowel screening is quite removed from that, and I think probably in future talks tonight we'll be hearing more about different things.
Yeah, I think, you know, it's a great reminder that this test, it does not make screening easy for everyone. And a lot of the patients, even the urban living non-Indigenous Australians that live in Darwin, they don't want to fill in that paperwork. They don't want that test kit. They don't want to put their poo in the mail. Like, there's a lot of shame around it. So they do use it as a prompt to see their GP and get the FOBTs and send it through Westerns or Sullivans or whoever is their pathology provider. But I think what you're doing in community, it really is tackling those grassroots. Like, it comes down to relationships and communication and education that you've obviously spent years of your life fostering, and that's incredibly important. And being able to have these conversations at home, in country, on country, in language, with people that they feel safe and comfortable with is incredibly important for breaking down those barriers. So thank you for your sustained work.
There's just a question online from Penelope Stevens saying, do you believe that your pilot can be transferred to other regional and remote areas of Australia?
I think they looked at it to see whether it would significantly improve the rates or not, and I think there's greater complexities than just getting the test kits to the patients. We need a well-established workforce that is stable so that these conversations can happen and patients feel more comfortable with the outcomes and where this journey might take them. Speaking to the GPs up north who have been living and working in these communities for a long time, they do feel that the confidence around colonoscopy has improved. I didn't get a sense that they felt as though the confidence in the fecal occult blood test had improved, but it's great to see that you're experiencing that in Central Australia using other modalities, not just the National Bowel Cancer Screening Test. One more? Time for one more? Okay. One more, last one.
I'm also a remote rural generalist, and
Thank you.
I think one of the things Kumali said is if there are elders who start the conversation, and I think that's a really important part of the chain.
Absolutely.
We also, I just made the call and got bowel kits delivered to the clinic, and I have had some buy-in from people who are happy to it's walking distance from a lot of the houses, the clinics, so they'll just come into clinic and they'll give me. And so there are no post boxes in our rural remote communities. So the clinic is a central point. And I think people are when it's explained, and particularly if there's an elder or a person who is a local person, explains in language, gives a little bit of sense of trust, that really promotes that. But I've had quite a bit of buy-in of people who are willing to do the samples, either of fecal occult blood or the bowel scans. And we send ours, I take mine into town when I go back, and I actually keep them refrigerated and pop them in the mail at a cool time. I don't know whether that works in terms of how fast the mail is from Alice Springs, but I'm very careful about that.
I mean, it's incredible that you're getting it done, and it's great to see that we are, we're actually seeing changes in perception and community buy-in, which
I
is
think
fantastic.
it takes time.
It does.
So I
It
don't know how
definitely
long
does.
the pilot was, but I've been talking to people for the last
Years.
couple of years.
Yeah.
And I am getting buy-in, but it does take time. The one big barrier is the registration.
Yes.
I don't have time to do that. And so it's the paperwork and the
paperwork's-
registration seems to me just,
It needs to be simplified.
yeah, or why can't it just be a labelled test with the same way as we submit CSTs, as Paula said.
Yeah.
Thank you.
Thank you so much. The next speaker hopefully needs no introduction, Professor Alex Basudis, who is the current president of GESA, is speaking to us tonight about the alternatives to colorectal cancer screening and what other options are available to us, to our rural and remote patients. Thanks very much, Alex.
Thank you. I'm also chairing this, so I'm going to have to keep ringing the bell and moving people along, including myself. So I'm tasked to talk about alternatives to colorectal cancer screening, but I actually want to really thank Kirsty for giving a really nice introductory, because the first 5 or 6 slides that you'll see overlap quite nicely with what she actually, so I'll whiz through them and, with what she actually said. This is a slide I'm putting up. I've been doing this for about 2 years now, putting up this slide in terms of the importance of gastrointestinal cancer, not only in our community, but globally. And colon cancer, which is the one that we always talk about, is extremely high incidence. And these are global rates. It's not Australia that I'm talking about right here. You heard local data previously, and I'll talk about some more. But GI cancer, and that includes pancreas, it includes hepatoma, stomach, esophagus, and those sorts of luminal as well as hepatobiliary cancers, account for almost 25% of the world's cancers. GI cancer is a big problem. What's worse is that it accounts for almost 35% of deaths of cancer across the world. So this slide, for me, resonates really importantly across the spectrum of communities that we talk about. I pulled data from AIHW, and you'll see a few slides that actually are screenshots from sort of analyses, if you like, that I've been doing, looking at 5-year survival data for cancer in Australia, and this is from the years from 1989 to 2018. This is the data I had, showing that we've actually been really good in cancer. But unfortunately, it's the good cancers are ones that we tend to screen for. And I've got an example there of overall cancer survival rate on the left that you can actually see, which is slightly going up, but up into the sort of 60%, 65% for both males and females. What you see on the right is esophageal cancer, which is one of the worst morbid and highest mortality cancers. And not only is the line flat, it's got a slight inflection, but it's actually extremely low at about 20%. This hasn't really changed for decades. So that's a problem. Now, what happens with screened cancers? And the 2 main screened cancers that we know about are colorectal cancer on the left there and breast cancer. And you can actually see breast cancer survivors are fantastic. And we've done a fantastic job with breast cancer screening. And that's the biggest factor that's actually resulted in these early detected lesions and has translated really well to survival. We're seeing really good uptick in survival of colorectal cancer on the left. And this, of course, is multifactorial. It's not only because of screening, but that's part of it. It's also because treatments have got better. The surgeons and physicians that treat this disease have actually got better drugs, and we are able to actually treat people more efficiently with it as well. So screened cancers look like they've got good prognosis, and you've heard that from Kirsty before, and this is kind of the moral of why screening is actually important. So this is interesting data that I again pulled off the AIHW, and what it basically shows on the left there is colon cancer incidence, and the bars basically show cases as we've been going by year, and it's been progressively increasing. What the line, the blue line and then the red lines that I've actually have as trend lines over there reflect is the relative age-adjusted incidence rates over that time. So what's the rate been doing over these periods of time? And interestingly, for colorectal cancer, at around the time we started doing colorectal cancer screening in a national systematic way, around 2000, where we started doing it piecemeal and then fully enrolled it back in 2006, we actually start to see an inflection. So we're starting to see incidence rates going down. So is this a success? On the other side, we've got breast cancer that we've been doing very successfully with good participation rates throughout that same time, but the actual incidence rates is still climbing there, that you can actually see. The rate's lower, but it's still climbing. So I think in colorectal cancer, we're doing something right, and this reflects in the elder population between 50 and 75, which is the screened population across the world. We're seeing the same trends in the US, particularly in other places where there's systematic screening. So are we winning this? The other thing to advocate for screening, of course, is this data, which shows that if you've got an early stage colorectal cancer and you diagnose it at an early stage, you do much better. And that's sort of a no-brainer. Now, what's the situation with First Nations? And Kirsty actually introduced some of this data. This is data that I've actually been able to pick up from the website at AIHW as well. Part of it's old, but the worrying thing is the colorectal cancer incidence, which you can actually see is the top line in both those graphs. On the left is Indigenous Australians and on the right is non-Indigenous. And it kind of reflects that inflection period. So this is from about 2000 to 2015, which is around the time we really started going with the National Bowel Cancer Screening Program. And you see that sort of flat line in the non-Indigenous, but this real escalation in terms of incidence on the left there, which worries me, because just looking at cross-sectional what's happening with incidence rates at this year doesn't show you this pattern, which is actually this increasing amount of cancer that's going to be continuing to grow until we do something about it. Down the bottom is mortality, and we can see that it's been decreasing in non-Indigenous, but increasing in Indigenous, and there's multiple reasons for this. Part of it that we know, we tend to diagnose it late, and therefore the outcomes tend to be worse in that sort of group. A recent paper that was published out of Queensland actually showed some other interesting data on early onset colorectal cancer, and Kirsty was quite right to actually point this out as a bit of an epidemic. I mean, the rates are really small, the numbers are small, thankfully, but the rates of increase of these poor patients under the age of 50 that are actually getting these cancers is significant. And this is data that basically looked at early onset colorectal cancer in an Indigenous population. They use First Nations here. The interesting thing there, and hopefully you can read that on the screen, is basically you are 2.6 times more likely if you're a First Nations person to actually have colorectal cancer under the age of 50. So this is first data that I've actually seen in this early stage, and it'll be interesting to see some more of it. The other interesting thing is remoteness, and this again was touched on by Kirsty previously. And this actually shows data that the more remote the First Nations people were, that resulted in higher rates of colorectal cancer and probably worse outcomes as well. The other interesting thing with this data from this paper was this very paradoxical thing, which was that females seem to have a higher incidence rate of colorectal cancer in this earlier age group than males. This is the first time I've ever seen this in the world, and I can't really explain it. It's small data, it's a small study, but it really brings home that there's something here that's going on that might need further study. The other interesting thing here, if you look at remoteness, and this is taking all colorectal cancer, it didn't really make a difference. If you take early onset colorectal cancer, it didn't really make a difference. It was all colorectal cancer that made the difference in that group. So what about participation rates? You heard it, and there were some difficulties about First Nations. This is data from 2018 there on the left that showed a participation rate of about 24.5%. Now, interestingly, I don't think it measures non-bowel cancer screening stuff. So this is from the National Bowel Cancer Screening Program, and it was at the same sort of time, about 40%, it was about 39.9, I think, in the non-Indigenous, but about 24%. More recent data looks at like it's about 34%. That comes from that study that I actually just cited, and also AIHW. The other interesting thing is that if you look at participation rate in non-Indigenous being about 41% or thereabouts, and I've got some other data that shows that, the interesting thing in our community, which I was actually a bit surprised by because the American data doesn't actually follow this, is that 86%, if you got a positive fit, you actually did have a colonoscopy, which is actually a really good statistic. Could be better if it was 100%, of course. This is just a screenshot I did just today, actually. I looked at this data today. And this is published 2024 data, which basically shows participation rates and National Bowel Cancer Screening Program outputs, or some of the measures that they actually have from previous periods. So this is from the last 4 years or 5 years, versus the current period, which was 2024, which is where this snapshot actually comes from. And you can actually see the previous period, which reflects what I was showing before, is about 40%. Now it's about 41.7%. Interestingly, the rate of positivity is about 6%. That's the same across the board. So this is using FIT. And then diagnostic assessment rates is 86%. So we're actually quite consistent and pretty good at actually doing colonoscopies when we need it. One discrepancy, however, about colonoscopies between Indigenous and non-Indigenous is the time that it takes. So it's about double the time that it actually takes to have colonoscopies for First Nations people, just because of issues of access. Screening, the principles of screening are these. I'm not really going to go into them, but basically the basics are you need a test that's acceptable, a test that's cheap, a test that's sensitive and specific, and a test that people are going to do. They're the sort of morals of what a good screening test is. And so I'm going to take you through a little bit of data of some of the other alternative tests to fecal occult blood tests and that are out there, and give you a little bit of the evidence, and we can actually have a discussion perhaps at the end of the talks in a panel about whether it's right or not. So the principles of screening are these. We want to actually detect the earliest possible cancer to actually enact the best cure. Now that's case finding. I actually think that there's probably a better way of actually doing that. And the reason this is interesting is because stool-based tests, if you look at it, you've got luminal type cancer that obviously will be shedding stuff in the stool that stool-based could actually detect. That could be blood, that's what FIT does, but there's DNA tests and so forth that I'll talk about in a sec. Now, the more advanced that you get, the more invasive it gets, and that you see those blood vessels that start to be involved. They're the ones where blood-based tests are probably more relevant, although the people that are selling these tests are hoping to actually get that early detection as well. But the part that you're not seeing with this, and I'll show you some data about this, is the non-malignant polyps. And this offers us an opportunity to actually reduce the incidence of colorectal cancer by removing polyps before they turn into the cancers. So the differences that we're actually seeing here, the only tests that actually can identify these earlier pre-malignant ones in a satisfactory sensitivity and specificity tends to be image-based. And with that, I mean colonoscopy, flexible sigmoidoscopy, and even CT colonography. But there's challenges with that as well. So this, in summary, from a review paper a couple of years ago, really summarises some of the stool-based tests and some of the blood-based tests. Now, the only real blood-based test that's really commercially available in the US only is the one that I've actually talked about there. There are some others that I'll talk about that have actually been published, but they're not commercially available at the moment. And what on the right, I've summarised a lot of the words that you actually see there, is the sensitivity, specificity, and importantly, the sensitivity for picking up adenomas as well, which is those pre-malignant stages that I'm talking about. Now, the important numbers are those sensitivity, specificity, mainly the sensitivity. That should be, the higher the better. Although if you can have very high specificity, it means that you're not going to be doing colonoscopies on negative people as well. And you can see there that they're roughly similar. The second test is basically a stool DNA test that's actually looking at not only DNA, I would say that it's also got a blood in it as well. So it's a bit naughty because it actually uses FIT plus the DNA test. So it's actually additive to what you're seeing with the FIT test there. And then the blood-based test, the summary is there, and I'll go through some of the data in a sec. These are the image-based, that non-colonoscopy but image-based. So there's capsules that people are trying to develop in the bowel, and they've all got some sort of limitations, but generally they're pretty good. The last one is basically CT colonography, which looks at sensitivity and specificity, and this is looking at a cut-off size of adenoma rather than colorectal cancer. And it's basically above. The figures that I've pointed out there are the ones above 10 millimetres. So this is quite a big polyp. And in colonoscopy, I think we pride ourselves on actually seeing much smaller polyps and removing them before. We actually call a 10 millimetre polyp an advanced adenoma. It's actually quite a significant, a big deal. So the other thing I wanted to talk about in terms of screening is screening using these sorts of technologies, particularly FIT and even the blood-based technologies, are really the first step. And it's really the case finding that we want. It's really trying to change from basically colonoscoping the whole population to actually doing a much smaller fraction of the population that hopefully will actually be enriched by the people with colon cancer. But all of them require a colonoscopy to actually do something about it, to diagnose it and actually to manage it as well. So what's the evidence for stool-based screening? This is probably one of the best studies that has actually come out. It was published in the New England last year. It was basically a study that was looking at two stool-based assays, fecal occult blood test, which is on the right there, and in the middle there is the next generation multi-target. It's a DNA test that's looking at methylation and various other changes of the DNA that's in the stool. And you can actually see, I could probably try and summarise it for you, the stool DNA test was better in terms of sensitivity, but not as good in terms of specificity for finding colorectal cancer. And these patients all had colonoscopy. It's 21,000, almost 20,000, just over 20,000 people that they did this in the US. So it's basically encouraging. The other thing that of interest is that precancerous lesions, which are those polyps that I was talking about, you can actually see very low sensitivity at actually picking that up, both for the fecal occult blood group and also for the group that actually had the fecal test, although it was better because it probably was picking up DNA that was being shed. And this is just a summary that's actually showing that you could actually see differential pickup of whether the tumour was on the right side, left side, whether it was in the rectum and so forth. What about blood-based? And this was one of the studies, it was actually in the same year of the previous paper, again in New England. This is using cell-free DNA from a company called Guardant, who's actually got this assay that's using a combination of methylation, genomic aberration and various other techniques and fragmentation of DNA, and basically did it on a blood test on people that were having colonoscopy screening. So they basically screened, I think it was about 12,000 12,000 people, of which I think 10,000 they used in this group, and actually said, can we do a blood test while you do your colonoscopy? And this was the pickup rate. It's about a sensitivity for cancer of about 83%. And there was a sensitivity, interestingly, for those precancerous lesions of only 13%. And again, this is really important for us to actually recognise, because this is not going to really push the bar to the left of those really early cancers that we hopefully would try and actually pick up with these sorts of technologies. And again, this probably reflects, because it's blood-based, it reflects the fact that these early lesions are not really metastasizing through blood, and they're not actually shedding into blood. So they're not seeing them. So if we summarize a lot of this, this was a modeling study that was published in the Annals of Internal Medicine a couple of years ago, that basically showed what happens if you model patients that have no screening, the black bar, screening with some sort of blood-based assay, which are the next bars along, the reds, hashed, and so forth, or a stool-based assay, including fecal occult blood test, and the fecal occult blood test is the brown one. Maybe, Frank, can I have the laser? And I'll try and point these out. So this is the fecal occult blood here, and then this one down the end is colonoscopy. And what you're seeing on this side is what happens to the number of colorectal cancer cases. So what reduction of colorectal cancers, reduction in incidence do you actually get? And it's almost 80% if you do colonoscopy. So really effective at modelling this going forward as a reduction of incidence of colorectal cancer. And what does it do to mortality? These are the colorectal cancer deaths. You basically see, 81% or thereabouts. Whereas these other ones, they're good at mortality, but not very good at actually reducing incidence. And this is for the reasons that I was talking about before. It's not detecting those earlier lesions, which is what colonoscopy is good at. Now, the graph on the right is basically a graph trying to look at the cost of this, looking at quality life years saved. So more to the right here is beneficial. So you've saved more lives, and you've actually allowed people to sort of go on with their life in a fully productive way. And then this is the cost of the test and what it costs. And we can see right at the right here, the best one is fecal occult blood test being done on a regular basis. And then the next one is actually colonoscopy, despite the cost and everything that we talk about. Again, this is modelling, and it's US based, but it's actually the next best test that's actually there. The next one is also a fecal test as well. These blood-based ones are just too expensive in terms of doing them, but still effective because they're actually on the right side of that curve. Okay. So the elephant in the room is participation. So not only do you need a great test, but you need people to do the test. And this is all the discussion that you guys were talking about before. So in Australia, it's about 40%, 41%, as we've shown in 2023. It's not great. The US participation rate of any sort of screening, for those that measure it, and that's going to be a bit of a caveat here to the statistics, is about 67 to 68%. The majority of those are actually being screened by colonoscopy. And I would say that the fascinating thing about the incidence rate of colorectal cancer over the past 20 years is in the US is that it's been falling dramatically for those people that actually do it. There's some question about whether that's exactly got to do with colonoscopy or by any sort of screening strategy, but I think it's a good association. Sorry, moving on. So one of the other things that I wanted to flag is this participation rate on probably one of the most recent, it's certainly the most recent study that's actually looked at invitation to colonoscopy screening versus FIT, basically, and to actually see whether people would choose one or the other. Interestingly, most did not choose to actually do colonoscopy, so they were randomised to be invited. Only 31% actually took it up, whereas 40% took up the FIT. Interestingly, this study showed no difference whether you had, despite the difference between colonoscopy rate and FIT rate, it was obviously different in participation, but the incidence rates and survival rates for colorectal cancer at the end of it were no different between them. So it didn't matter what you did, they were both as effective in their outcome for screening. Now, interestingly, they actually cite 30% of the colorectal cancers found were actually for symptomatic reasons or having a colonoscopy for no other reason. So it's something they didn't really elaborate in the study, but it was interesting. The other thing, and I've been flagging this a few times, is adenomas. So these colorectal polyposis or advanced colorectal lesions were not really detected in FIT. They were much highly detected in the colonoscopy group, quite significantly. And this is typical of what we see. The other study that's been cited many, many times, that was published back in 22, was basically trying to randomise people to have colonoscopy for screening. This was done in Europe, mainly Poland and Sweden, and it was criticised. It basically showed that on an intention to treat, there was a slight reduction in incidence rates in the people that were having colonoscopy, and that's what this graph refers to here. But when you take, the participation rate was really poor throughout. It was 42%, and this was the criticism of the trial, that people weren't doing colonoscopy, and so it was criticised because of that. But if you take the per protocol data, so the people that actually did do the colonoscopy, it led to a 31% reduction of colorectal cancer and almost a 50%, about 45% reduction in deaths from colorectal cancer. So it does work, and it works quite well for those that actually do it. Now, of course, the problem is doing it. And so I'm not going to elaborate on these because Kirsty did such a good job of actually enunciating what the problems in a remote community are. And we've talked about it, and we can talk about it perhaps at the discussion as well. So my take-homes are these. Screening is good. Screening is important. Screening has actually made a difference, I think, in our community as well, despite poor participation rates. Probably the most pragmatic and best test is the fecal occult blood test because of its characteristics of being cheap, and it's relatively sensitive and quite specific. But for case finding, it's not really great at actually finding those early lesions. There are alternatives. So the Americans actually have an alternative screening strategy which they perform in 61% of their screeners, which is colonoscopy at every 10 years. Now, that's expensive, but like I said, the modelling of it is not that much more expensive than what we're actually doing with a program that sounds like it's not even working in many places because we're not actually measuring the data properly. There are blood-based tests, and what this graph actually shows is that for those refusing to do colonoscopy, so 60%, as I've been seeing in participation rates, that people don't do it, what if they just do a blood test just in that group? And you actually can see colorectal cancer finding improving the more the people actually participate in that. So I think that's really of utility. I just want to end by flagging a bit of marketing for this year. We've got the World Congress of Gastroenterology that's going to be as part of the Australian Gastro Week in September of this year. I invite you all to come along. I think these sorts of things are going to be discussed, and there's certainly a rural session in that as well. And with that, I'll end, and I'll quickly introduce the next person. But I'll take burning questions, but I want to try and move along. Thank you. So, Alex.
Our preparation requirements might be less intensive?
Yeah, it's a good question. The NHS have just canned it, and I think that's telling. I don't think it's worked very well. And the initial studies were fantastic. They were great. Of course, flexible sigmoidoscopy only goes a third of the way around the bowel, and so it's certainly going to miss a lot of lesions, which has always been the concern. In our community as well, flexible sigmoidoscopy, in the UK, they were able to do it because there was no sedation, and so the costs were much, much less. We still sedate people with flexible sigmoidoscopy, so that the cost benefit is not going to be as great. So I might kick off with the speaker, if that's okay, and introduce Sneha John, who's the head of endoscopy at the Gold Coast University Hospital. She's trained in the UK, but don't hold that against her. And she's one of our expert endoscopists who's visiting with us this week. And over to you, Sneha, to talk about endoscopy and what we do in colorectal cancer. Thank you.
Good evening, everyone, and thank you firstly for the very warm welcome to Alice Springs, and to Matthew and his team. It is humbling to see your commitment to the word you used, I echo, to do more or the most for your patients with what you have. So thank you for letting me participate, and also thank you to GESA and the Gut Centre organisers. It's my first time here, and I hope to come back many a year now, having met you all. My remit was to talk about how to manage what we find, and Kirsty and Alex have very elegantly shown you the capacity to find these lesions and how we may best do so. So now we move to the second part of it. What do we do when we have people who have undergone our screening procedures or colonoscopy for symptoms and we find advanced lesions? So the talk is going to focus on what we do for these advanced lesions, and I'm not going to talk about polyp resection overall, which I'm sure many of you performing this are experts already. Why is this important? We know that the overwhelming majority of colorectal cancers, and this is absolutely true in Australia, arise from clinically significant polyps. In my unit, I constantly remind my trainees that this is also one of the greatest privileges of being a gastroenterologist, that we actually have a malignancy that we can impact or prevent or modify and achieve better things for our patients because we can detect them early and manage them efficiently. So we should be inspired rather than find this challenging. What do we mean by advanced adenomas and clinically significant sessile serrated lesions, which are what we are truly focused on? Alex touched upon this. All polyps 10 millimeters or greater as adenomas we consider advanced. There's a bit of debate about this, but this is the general consensus. There's also a bit of debate about villus morphology, but in Australia, the presence of villus morphology we consider a feature of an advanced lesion, and definitely the presence of high-grade dysplasia. Sessile serrated lesions are considered to be clinically significant, again 10 millimeters or more, or the uncommon ones that have dysplasia, and we do have a rare subset which already have a small focus of cancer. So obviously we want to detect these early, and we want to aggressively and meticulously manage these. We prefer endoscopic management. I'm sure my colorectal counterparts, and we were having this discussion with Xavier this morning, would agree that we prefer, whenever possible, when we can achieve therapeutic curative resection endoscopically, we prefer it to our patients and ourselves if we are discussing our own organs, because it's minimally invasive and organ and function preserving. The advances in this area in the last decade have focused on detection as well as therapy, and might briefly touch upon why that is. But the resection strategies I'd like to take you through this evening, which are to decide, are we going to do a complex mucosal resection in a piecemeal fashion, or do we need to focus on an en-bloc resection, and why should that be, and when do we do each, versus the newer concept of some patients may require, or some lesions might require, an even full thickness resection. So we're moving closer to both surgery and oncology in thinking about this. So you'll hear words such as EMR, which is the mucosal resection, ESD, which is submucosal dissection, and FTRD, which is full thickness resection with a specific device. Now, I usually start training in my unit by saying, yes, everyone's here to learn really cool things, right? Resection. But we can only resect what you detect. So you got to detect. And anyone who wishes to manage these polyps, we should also get very slick at finding them. Earlier the better. So let's use every technique and technology available to you. By the way, Matt, you've got the best endoscopy system currently, or one of the best, in your hospital. So we have technology available to us, and we were using that today. So very simple things, which you don't need technology for. Can I see a show of hands for those who scope here, who routinely do a second look in the proximal colon? This is actually in the colonoscopy care standard, by the way, nationally. We did manage to get that word in, that we'd strongly advise. So routine second look, it doesn't matter how you look. Some people are very didactic about retroflexing, that could be. A forward view is fine. You can use a distal attachment like a cuff or a cap. Every one of those has been proven in various studies to have up to a 5% adenoma detection. So before we start anything fanciful, just having a second look. Cleaning, looking is important, because that could be the patient you find a 15 millimeter flat advanced lesion behind a fold. That changes outcome. Do you need fancy technology? Well, we've already got a lot of advanced imaging. There's a lot of debate about detection data. Lots of meta-analyses looked at this. LCI has some promising data in randomized controlled trials. NBI is mostly used for characterization rather than detection, although the newer versions, and texture and contrast enhancement largely. Everyone wants to know about artificial intelligence. I might disappoint the AI fans in this room by saying, currently in 2025, for detection of advanced adenomas, AI is not there yet. In 2025, the data does not show that AI as yet has reduced colorectal cancer incidence or detection or mortality. Probably it's too early, and I think time will tell, and technology will evolve. So how about the topic that's of most interest to us? What do you define as a superficially invasive cancer? These could be small foci of cancer and malignant polyps, which are superficially invasive, which most of you would be familiar with. But we've also advanced to consider flat advanced lesions with early cancer, which can be up to the superficial submucosa. Now, I'm not a pathologist, but if you put 10 pathologists in the same room and ask them to debate in Australia what they mean by superficial submucosa, we could be here all night. But we do have some general consensus about what we mean by the superficial submucosa and how we divide it, under a microscope. For the endoscopist, it's not always easy to say I'm in the superficial submucosa. So how do you assess features, if you keep it clean, to say, is this resectable endoscopically? Am I going to get a safe and the best outcome for the patient here? Can I exclude deep invasive pathology, which almost always requires surgery, unless the patient's unfit? And then after resection, what do I need to focus on? I've done the job, but have I done a good enough job? And have I done an oncologically appropriate resection or an R0 resection, for which we look at several pathological factors, which are again hotly debated. Now, I'm challenged by this, because in Australia, we have no guidelines except the Coloproctology Society has guidelines on depth. Now, increasingly, colleagues around the world are saying depth is no longer the decider here. And they're all changing guidelines from 1,000 microns to 2,000 microns. Serious data review recently suggests tumor budding and differentiation are the most important factors to predict. What do we want to know for our patients? I've resected something. What are their 5-year and 10-year risks for metastases? It's very seldom local recurrence that we're worried about. It's lymph node metastases and distant metastases. So we have a risk calculator, which is now evolving and changing. And of course, it makes sense that we want to look at lymphovascular and neural bundle invasion. There's also debate, if I have a 6 centimeter polyp, does the size of the actual malignant focus make a difference? There's some data from the National Cancer Centers in Tokyo that if it's a very small focus, 5 millimeters or less, maybe the risk is not quite the same, everything else being. So perhaps the evolution now is to get consensus in guidelines so that the worry is, are the wrong patients getting operated on? Are people losing their rectum? If someone says, oh, up to 2,000 microns was curative resection, but we've gone by 1,000 microns and taken out someone's rectum or given someone a permanent stoma. So I think this is still an evolution, and I think colleagues need to work together. So how does an endoscopist like me determine resection strategy? I start by saying, is the treatment option acceptable to this patient? And that needs consultation. You can't just cut a polyp like this just by meeting them for the first time. We've had a conversation, surgical colleagues might have had a conversation. There's a clinic consultation. You think about the age of the person, their comorbidities, an individual risk assessment. Medications matter, understandably. Do they have anesthetic risk which make them unfit completely for surgery? What's the limit of care there? And if I do have a complication and they have such high risk that they never were candidates for surgery, what are we willing to accept? Is it a bit of bleeding we're willing to accept? Is it an area like the rectum where perforation is less worrying and easily managed? So these are very important conversations to have with every patient. So individualizing your patient management, just like most things in medicine. Lesion determinants, I'll take you through in detail. The morphology and the surface of the polyp matters. Using specific imaging matters. Using specific classifications matter. Sometimes you have to do a planning endoscopy to be meticulous and get this, especially if you get referrals from elsewhere and all you got is 3 black and white pictures. And you're asked to say, can you do an ESD? Sometimes you have to do a flexible sigmoidoscopy to make the best judgments and then decide the depth of invasion. I wanted to put this because it's very challenging to discuss that despite your best intent and will, sometimes what is available to you also makes the decision. So proceduralist and local expertise, would you get leave to go somewhere and train adequately? Would you get leave to go somewhere and be proctored by people? Would someone be willing to proctor you in your first 10 cases, even remotely? Would you have funding to have admissions for your patients after complex resection? We've had to fight all this, so this journey is very familiar to any of you starting a service. To buy a knife for an ESD is not that cheap. The time is 3 hours sometimes, maybe more. And so Ben always says, you know, might have had a decent resection by then surgically, but I've spent 3 hours cleaning up a polyp, and then you find submucosally invasive cancer. So time is money, the accessories are money. So all of this you got to think of if you're planning to do these. So now just some factors that all of us can use in routine practice, just like the second look. Get very familiar with the Paris classification. Morphology matters. Most pedungulated polyps, with rare exception, even the largest ones can be managed endoscopically. But then we are a bit more concerned with very large, bulky, sessile polyps. The location also matters. You want to look for any clear features of depression, ulceration, things that worry you about deep submucosally invasive. And of course, if most of it's excavated, deeply ulcerated, it's a no-brainer compared to a very flat, reassuring, slightly elevated polyp with no bulk. Why is this important? We hear the word lateral spreading tumor, LST, used more frequently in literature. Granular is usually very homogeneous, a few nodules, not much bulk, smooth surfaced, whereas non-granular is the opposite. The difference is the risk of submucosally invasive cancer. Flat lesions, you can look at all of it. So the way we often talk to patients, it's like a dinner plate, very flat, so you can go and look at every bit of it. More of the mushroom type of polyp, you don't know what's under the umbrella or the head of the polyp. So if you get more bulk and it's smooth, or you have an irregular surface, you may be hiding up to 38%. You add a bit of depressed morphology, could be as high as 80%. So you've got to be very careful with those lesions. So these two are very useful things in daily clinical practice. This is a little bit more challenging. Disappointingly for me, less taken up in Australia than I anticipated. A lot of rapid uptake now in Europe, and this is a Japanese classification. Professor Hewitt, who is one of my colleagues in Queensland, was involved in the NICE classification that you're all very well aware of. It's very useful for routine practice, but I like to challenge David now frequently to say NICE is no longer nice enough for the type of decisions we're trying to make for these polyps. So NICE 2 may hide high-grade dysplasia and superficially invasive cancers. NICE 3 is type 3 in GENET, which is deeply invasive cancer. But the challenge for GENET is to differentiate these. 2B is still endoscopically resectable, but you're looking at advanced techniques like ESD, you need magnification. And magnification endoscopy is not routinely taught in our centers. Whereas NICE is helpful to say, this is not cancer, this is a simple adenoma, etc. So something we will get familiar with, hopefully over periods of time. Now going through the techniques, dissection versus EMR, why should we bother? You obviously get better pathology and en-bloc resection with lower recurrence when you get an en-bloc specimen. A very large data set from the Australian colonoscopy study in expert centers, in expert hands, still had 27% recurrence in complex piecemeal EMR. We have learned to manage this. Most of these are manageable endoscopically. Rarely do they need surgery. And now with better refinements in technique, with snare tip soft coagulation, we brought it down. How about the feared complications? Except in the rectum, perforation rates, particularly in the proximal colon, are higher in ESD. The resource requirements, as we talked about, are very intensive. Bleeding rates, this was a very surprising thing for me. I expected more bleeding with ESD. In fact, they're very similar, including for patients. Probably is the technique, and I'll show you a video. There's better management of vessels in ESD. You're not so blind as when you're cutting an EMR. So these are the societal guidelines. For the sake of time, I won't go through these. They're largely similar. This is the strongest Western guideline. The Japanese have been around for like 10 years talking about this. The only significant difference is, obviously, you want to look at concerning lesions and go for ESD. The Japanese are also pushing the envelope for submucosal fibrosis, whether it's a recurrence. We were discussing a case like that this morning. But they're also talking about inflammatory bowel disease, which is very pertinent in Australia. But, we've only started to think about ESD and IBD, which is quite hard with inflammation, kind of in the last 2 years. The Japanese data that stands out for me, which always inspires me, look at the second sentence for the survival rate after endoscopic resection. This is largely for T1 cancers in the rectum as well as in the rest of colon. I'm not sure if this is absolutely achievable in the West yet, because these are very expert centers in Japan who've done ESD for like 20 years, pioneered these techniques. But this gives me hope that this is what we are aiming for. And again, a conversation with Xavier this morning, we intend to fight tooth and nail to keep the rectum of every human being, if we can, and I think the colorectal surgeons feel the same. So that day is gone where we think, oh, we got a T1A cancer in the lower rectum, let them have, ultra-low anterior resections and have their life changed. 35-year-old women can have surgery, or let them have a permanent stoma. That era is gone. We are better at imaging, we are better at working together, and that should inspire us. How about Australia? When I started rectal ESD in 2018, there were some criticisms from very expert colleagues who thought, why are we needing to do this? Our EMR service is brilliant. Yes, that is true. But I read a philosopher who said, when facts change, I change my mind. How about you? So in 2018, I needed to change my mind because it wasn't good enough for my patients with rectal lesions. Then Professor Burke came out and published this paper in Gut in the latter half of 2018 saying, how about a selective strategy where if you have concerning lesions in a very large data set, so keep this number in mind, we have 43 ESDs, but it was highly selected in that initial cohort, and they found that that was a safe and cost-effective strategy. So we don't really need to say every rectal polyp needs an ESD. That's not the theme here. Select your patients to achieve the best outcome. I'd forgotten to put the slide in because I thought, well, you know, I am a Queenslander. We're all for cold EMR and the cold revolution. We don't get enough cold in our state. So we like cold in any shape, form, or kind we can get it. There isn't much of a role for superficial cancers, but I just put that in to say any sessile serrated lesion of any size can be managed extremely well and elegantly by the cold technique. But just a word of caution, because it's such a safe technique and nice technique, the learning curve is less. Adenomas, be cautious, because they do hide things that SSLs often don't. And the depth of the cut is not as deep as we want it to be. So lesions greater than 2 centimeters, the guidelines are only up to 15. You have to be absolutely careful that you image them nicely and there are no concerning features. The 2 significant RCTs recently and the data for cold is not as good as yet. So the final 3 or 4 slides is actual pictures. We talked about all this. What does this look like in real life? This is one of my 78-year-old patients. She had a near circumferential rectal polyp. This was about 12 to 13 centimeters. I had a little mucosal island, as I'd like to call it. But the nice thing about this polyp was granular. This looked like a little bulky component, flattened out with buscopan and water. So very extensively a Paris 2A lesion with the morphology we talked about, imaged with magnification, very regular pits. So this is also a basic tip for everyone. Just look for regular, keep it simple, regular pits, regular vessels. You're not concerned. And no depression, no ulceration. Irregularity should bother you. She's very nice architecture. So we make a decision. She's on apixaban, by the way. Who isn't? Maybe not DAPTs plus apixaban. So I was grateful. And so you do meticulous examination and piecemeal technique for EMR. You got to clean every little island. Takes about 90 minutes to 100 minutes to do this well. ESD would have taken me 4 hours. And that's not needed in this person for this lesion. Pathology was favorable, no cancer, high-grade dysplasia only. She does well. But recurrence rates are high, so you need to use your snare tip, coagulate, make sure you haven't left any islands. Contrast that with this polyp, another one of my 75-year-olds, also on a NOAC, big bulky lesion, 4 centimeters from the anal verge. So the consequences, the game is on here. The consequences are more significant. Big bulky component, so more Paris 1S. Focal irregularity, this is where JNET kicks in, JNET 2B, at least in a small focus. So we are concerned already. If we don't get a high quality resection here, if the pathology is doubtful, we're going to be sitting there for 3 days debating microns, right, for surgery. So we want to avoid this. So on-block resection here, ESD technique, and the specimen gets the best pathology. There was T1A cancer with favorable features, and he's done well. So just want to show you the video. Hopefully, I can make it play by. Can you play it, Frank, from your end? Yep. So this is 2018, so I feel old watching this. This is one of my first few cases. And back then, I used to use a scissor-type knife. Knives have evolved. There's a lot of choice now. Back then, you had 2 or 3 choices. So this is a technique very similar to peroral endoscopic myotomy, where you create a pocket. But I wanted to show you, this is what the pocket looks like. It's very nice when you're in a nice plane. So muscle is below you. Mucosa and submucosa is above you. So this is called a clutch cutter. It's a fast knife bend. It doesn't take me 3 hours. But it's also, you have to be able to manage it. So you dissect each part of the submucosa with cautery, and you divide it away from the muscle. Muscle is the white sheeny structure below you. Now the other advantage of the modern day knives, and we've advanced significantly in this area, is you can do electrocautery, you can do injections, you don't have to swap out too many devices. So we're getting faster, in Western units. So another little bit of dissection, this goes on for, and so now I'm gonna, after that little cut, so I'm going more superficially. Just wanted to bring you, so a little bit of bleeding. Let's see what happens. There you go, little arteriole decided to bleed where you had cut. So you just use the same knife and you give it a good buzz for a few seconds. and then you can continue to dissect that area. So you kind of do this constantly. You just need to squint a bit, and you usually have a good pressure mat so that you can stand and improve your circulation. So this is the final picture slide before our summary. This is a full thickness resection device. Didn't have time to show you a video. I'm still challenged to pick the right lesions. Neuroendocrine lesions in the rectum, absolutely. Superficially invasive cancers, perhaps CSD is good enough, although there are Northern European colleagues doing FTRD. Scars, yes, probably a very good indication. So you have a grasp of that grasp, the tissue you want to resect. There's a size limit, about 25 millimeters or so. Once you've grasped the tissue, you deploy an over-the-scope clip where the hole is going to be so that you don't have a perforation, and then you resect above that. So I hope in summary, I have convinced you that there are many advances in endoscopic resection for our patients, and we are still refining the best strategies for managing advanced polyps and superficial cancers, but they should always be aimed at achieving the best outcomes for our patients. That requires time, a multidisciplinary approach. We have a complex polyp MDT where a colorectal surgeon and I sit down, and every 3 weeks we look at this and we debate back and forth what may be best for that person before and after resection. There are many exciting advances in technique. One of these is, can we go one step further? The next level of invasion, how do we preserve the rectum? So there is endoscopic intramuscular dissection now. It's very early days. So you go into the muscularis propria and you dissect out the circular layer, which in the rectum is robust enough, and the longitudinal layer will hold, is the principle. Right now we're doing it for T1B cancers, but we're also thinking about, with advances in immunotherapy and chemorad, there may be people who only have that, and once the primary has shrunk, we may go back and do that. That's something I am excitedly waiting to see. AI may help, not in detection, but perhaps may help in depth assessment, which we are not always great at. It may help in making that decision easier. Is this en bloc? Is this superficial? And I think there may be some detection possibilities for advanced lesions too. So with that, I thank you for your attention, and perhaps we'll take questions at the very end, unless there is anything burning right now.
Thank you, Sneha. And you can see that there's some method in the madness of the order that we're going through. We've done screening, we've detected polyps, we've now treated some of the polyps. Now we're going to deal with the ones we can't deal with and go up a level to actually, and I'll invite our friendly colorectal surgeon up, Xavier Harvey from Bunbury, who actually I think many in the audience might know because he visits here quite a lot and does a lot of colorectal surgery here, and actually works as a general surgeon as well. You're going to give us the next step in the evolution, I believe. So over to you, Xavier.
Thanks for leaving us something to do, Dr. John. Thank you, everybody. Thank you, GESA, for inviting me. It is great to be back in Alice Springs, so thanks to the local crew at the back there. Surgical approaches to colorectal cancer, I've got that as a topic, and I was like, gee, that's pretty broad. But luckily, it's probably also no secret that we're not as clever as gastroenterologists, so it is quite simple. Basically, we take colons and we turn them into semicolons. And that's about it. But I did think, how do I go forward? Right, well I thought also, because there was no further instructions, I thought it's a dinner presentation too, so I thought maybe I can just go rogue. You know, like, there probably aren't that many other surgeons in the room as well that do this kind of stuff all the time. It's like, what's new? What's on the horizon? And when is it now actually not just, this is cancer, let me remove it? And there are a few things that are maybe in the pipeline already well underway that I thought I'd just bring up over dinner, and you can chat about them later. So one of them is neoadjuvant for colon cancer. The German rectal cancer study came out over 20 years ago now, and some sort of neoadjuvant therapy has been standard in most rectal cancers ever since, except for really early ones. But for colon cancer, that hasn't really been the case. Generally, it has just been a case of it's cancer, chop it out. That's pretty much it, with the exception of very locally advanced disease where you don't think you can resect it up front. The next one is TNT. So the German rectal cancer study I just referred to was about putting neoadjuvant radiotherapy before rectal cancer resection. I think that was 2004 or something. It was an absolute game changer in our world. But then over the last 5 years, they've gone, oh, maybe we should do the chemotherapy component as well before that. And like, even in my time now, I think most MDTs around Australia for locally advanced rectal cancer have changed from being routine chemotherapy based on a pathological assessment after resection to now pre-op MRI assessment, and we make a call on that. And most people with locally advanced rectal cancer, that means T3 or above or node positive, they get TNT now. And that really does change things in slightly unpredictable ways as well. And then the last one is organ preservation in rectal cancer. This probably shouldn't be as profound and revolutionary as it seems. Like, we actually don't chop out a lot of organs that get cancer. Like, anal cancer for years has been treated generally very successfully with the modified NIGRA protocol. And esophageal SCC, like, most of them don't need surgery. Where are we at with rectal cancer with that now? It's changing quite quickly. And I think a lot of us don't really know what we would want if we got rectal cancer. And depending on the stage, I think it really is quite challenging decision making. And great dinner time chat. So neoadjuvant chemo, yeah, the Foxtrot trial just seemed to hang around for decades. There was this huge study done in the UK, 1,000 patients. Getting 1,000 patients with colon cancer into a trial is no mean feat. And they basically did, everybody with colon cancer gets pre-op CT anyway, and if they've got METs, that changes things, but otherwise they get an operation. But they said, oh, if it looks like they've got positive nodes, which is usually the deciding factor, right? If you've got positive nodes, you go for adjuvant chemotherapy. So they said, well, if it looks like your nodes are positive on the CT, maybe we should give you chemotherapy first. And also, that's not revolutionary. There are a lot of biological reasons why giving chemotherapy before surgery makes sense. You get an in vivo test of the biology with the treatment you give. And what actually kills people with colorectal cancer is metastatic disease. Like, their biggest threat to life is their micrometastasis. It's not the local disease. And the treatment for that is chemotherapy. So give that first. That's what matters more. But it sort of just hasn't, like, it's taken till now before we get this 1,000 patient trial. Anyway, so the results of this were published, I think, a year or two ago now. And long story short, don't know. Like, there was maybe a signal to better response. Like, it was only 2-year follow-up. And 2 years isn't really long enough in modern colorectal cancer. Very few people die or progress a long way in 2 years now. But there was a signal that people are less likely to have their cancer recur if they had neoadjuvant chemotherapy. So it definitely has led to a bit more movement in that space. But the big issue was a lot of the nodes that were thought to be positive on CT weren't positive. So all these patients are getting chemotherapy that just don't need it. Because our preoperative diagnosis is just not good enough. And it's not practical to do biopsies of these. And so I don't know what we're going to do about that. Maybe AI, radiology, will be better at deciding whether nodes are positive or not. I don't know. We talked a bit about liquid biopsies, maybe a blood test, maybe like circulating tumour DNA, maybe if we can do that, maybe that better picks who's at real risk of micrometastasis. We don't really know, nobody knows, but it's dinner time chat. The other thing is the DNA analysis that goes on now. So personalised care is obviously not an all or nothing phenomenon in cancer. A lot of us are already doing it. Like cetuximab, bevacizumab, immunotherapy, they've been around for a fair while now in a metastatic setting. And all of them are based, like the decision to give them all is based around the actual specifics of the tumour biology. But they've done really well. That people at stage 4 cancer now live a lot longer than they used to do. But they've all been extremely disappointing in the adjuvant space. So what I mean by that is if you take out someone's colon, it looks like high risk, they should have treatment. If they've got, say, MSI tumours that do really well with immunotherapy when they're stage 4 disease, it doesn't seem to help much when you give it after you've actually removed the tumour. No one really knows why that's the case. It should work. Similar thing with cetuximab as well. But maybe that's where neoadjuvant therapy is going to be really good. Maybe if we give it to them when they've still got a cancer in situ, maybe that's when it'll make a difference. I don't know. My suspicion is it will. Anyway, that's enough about neoadjuvant therapy in colon cancer. Because really, as a colorectal surgeon, like there's colon cancer and there are rectal cancers, and they're just completely different beasts. So we'll move on to rectal cancer now. Yeah, like I said, TNT, it's gone from, there were two really important trials that came out over maybe 5 years ago now, and the difference wasn't with local recurrence, which local recurrence used to be the big enemy of rectal cancer, like in the bad old days in the 90s, 30% of people with rectal cancer would come back with local recurrence. And you'd probably often better off dying than getting local recurrence from your rectal cancer. Like, it's truly a fate. It's just terrible. Anyway, with radiotherapy and probably better surgical techniques, that's become very rare. It's less than 5% now, but in practice, you just don't see it much. But people still die of their rectal cancer because of metastatic disease. And so these trials, like, they were only looked at locally advanced cancer, but they showed a clear mortality benefit if you give chemotherapy before your surgery. And one of the reasons for that is because then you actually definitely get it. Because if you get your surgery, have any problems, don't go on to chemo, you don't get the benefit that you need from the chemotherapy. Anyway, so one of the things that happened with that is, okay, you give TNT, you give radiotherapy and then chemotherapy, and then roughly about a quarter of those patients, you do an MRI, flex your SIG, you'd examine them, and actually had no residual evidence of cancer. So they've had what we call a complete clinical response. What do you do with that? And then, like, 25 years ago, the same group that really popularised the watch and wait group, the Harbour Gamma group in Brazil, they like inverted commas, patients that refuted early rectal cancer. So early rectal cancer was good for surgeons because it's like, finally we get to do what we do, remove rectums, right? But they, you know, if we talked about 25% of people getting a complete clinical response with locally advanced disease, they gave chemoradiotherapy and then chemotherapy to people with T2N0 disease, and 85% complete clinical response. And if the problem with watching and waiting in the locally advanced group is that maybe a quarter of them will grow back, and then when they grow back, that's maybe not an ideal situation, and maybe that's reason enough we should still be operating, I don't know, anyway. But if it's 85% response, and then presumably their risk of regrowth is also much, much lower, like, are we going to be left with anything to do? And then you think, okay, so we are going to do something, we're going to move it, and maybe there's just a little bit of regrowth there. Should we do like the big operation, you know, rectal cancer? That's, you know, very exciting. What we didn't mention is just how much fun it is doing that. Or do you do the little op, which is really fiddly? And so, like, a lot of the things that Dr. John would manage endoscopically, I do with a TAMIS. It's like doing laparoscopy, but through the anus. I guess that's just how you trained, right? And there's no local gastroenterologist in the region. So if you are a gastroenterologist and you're interested in coming to Bunbury, it's really close to Margaret River, like fantastic surf, world-class wineries. Anyway, but yeah, should we be doing the little operation or should we be doing the big operation? And then the other question is, well, obviously you do the little operation, right? You preserve the rectum. Having a rectum taken out is miserable. But then you think, so if you do the little operation and then you look at the risk factors on that and you think, oh, maybe you should do the big operation. Have you lost anything by doing the big operation first? And I think for a while we thought maybe not, but recent data suggests you do. In fact, the quality of the TME we get is not as good when you do the TAMIS first and then go on. So you probably should make that decision first, actually, because once you've gone through you should never trust an organ without a serosa, like the esophagus or the rectum. So the rectum's not like a normal GI tube where you've got, you know, muscle then serosa. Once you go through muscle, it's just sort of, you're in the pelvis. And if you do the TAMS and you go through the muscle, you've probably changed the natural plane that we'd be operating on with rectal cancer surgery. So you probably do actually lose something by doing the little op before you do the big operation, which only makes it harder to decide. And then I just thought I'd put this up as for, because it is hard to decide. It's really hard to decide. And it's really hard when you're not sure as the clinician what you think the right thing is to do. And then you've got a patient coming to you for advice. How do you sell that to them? Like, objectively, and let them really be in charge of the decision. Like, it's quite challenging. But yeah, for locally advanced rectal cancer, I think these are roughly the numbers. Somewhere between a 24% chance that if we give you TNT for your locally advanced rectal cancer, you'll have a complete clinical response. If you don't have a complete clinical response, you should get a total mesorectal excision. I don't think there's much debate about that. There are some people that will push the boundaries on that. They'll say, because interestingly, if we say you get a complete clinical response of 20 to 40%, if you don't really assess that hard and then just wait, about 50% of people have successful organ preservation. So there's probably a group of patients that you get away with it anyway. It's about how you do that assessment for complete clinical response. Anyway, that's a side note. But roughly, you've got a 1 in 4 chance of having a complete clinical response. And then if you have that complete clinical response, you've got a roughly 1 in 4 chance that that's not going to be sustained. At some point, the cancer's going to grow back. And maybe if we do salvage surgery, like 90% of those regrowths are luminal, which mean they're in the, like you put a camera in, you can see them easily. And then hopefully if we do the surgery, you're going to do just as well as you would have done if you did it at the start. That's probably true, but no one really thinks it is. Certainly the operation's not as easy. And if you're one of the 10% that don't present in the lumen, well then presumably you've got regional, and you're exposing yourself to risk of distant disease as well, which is what you could die of. If we remove your rectum, another word for an ileostomy is an iatrogenic enterocutaneous fistula. You've got a 100% chance of having one of them. And then after that's reversed, really you've got a 100% chance of having impaired function. What would you do? Anyway, thanks for listening. Thanks for inviting me. It's great to be back.
Thanks, Xavier. Nice to have a pragmatic surgeon on hand. Thank you very much. Like I said, we can have a discussion towards the end. It gives me great pleasure now to invite Matthew Links, who's the head of oncology here at Alice Springs Hospital, and he's trained both in Sydney and Gold Coast, I believe, and he's going to talk about multidisciplinary care and some of the vagaries in the outback. Thank you.
Oh, I've got ahead of myself. So thank you for the invitation. I'm from GESA, and it's a fabulous project. This long-term relationship and support is really very much appreciated. And I'd like to also acknowledge the elders, the Aranda Nation whose land we're on, and also the generosity for which they've welcomed us into the community. I'm going to talk a little bit about multidisciplinary team meetings and a little bit about broader multidisciplinary care. This is a pain. That's one. So we all know what a GI-MDT looks like. It's got the usual suspects, sitting around a table, and it's really good at establishing the pathological diagnosis, at determining the stage, and making an evidence-based treatment recommendation. If you look at the people in the room, it's pretty medical. There's unusual to hear the voice of a social worker or whatever in the meeting. But it's very good at what it does. For us, in a remote setting, we couldn't manage our patients without the support of MDTs outside of Alice Springs. We get fantastic support from Darwin for some MDTs, and particularly from Adelaide. And that's particularly difficult for me, because if you're an oncologist in a remote setting, you have to be a generalist. And so I don't have the expertise anymore to really the deep dive that people who subspecialise in a GI cancer do. So really important for us to lean on the expertise of the people in the subspecialty MDTs. MDTs do that, are a great support to us. And I encourage you that if your MDT is in that situation, to providing that collegial support is really important. The typical MDT is not so good at some other things. Evidence-based medicine and the trials, etc., the population-based approach. And one of the things that's difficult is assessing, say, fitness. So geriatric oncology is a nice example where you can often have a patient approaching 80 who's put up for where the evidence-based overall population might be neoadjuvant FLOT and then gastrectomy. But is that patient fit for it? It's hard to assess those things, without seeing the patient. And maybe one person's seen the patient. But providing that sort of advice is difficult. So apart from the evidence-based medicine that's delivered so much for us being able to improve care, one of the other themes that is very much in people's minds is personalised medicine. And there's a high-tech version of that, and a good example is a molecular tumour board. So increasingly, if the decision is about whether a person's interpretation of their whole genome sequencing or access to a targeted drug or an unusual targeted drug, you've got to have a different sort of MDT. You need to have different people in the room in order to be able to provide advice on that. And so you convene a different MDT for that process. But the personalised tumour board, a molecular tumour board, is a high-tech version of personalised medicine. There is a low-tech version of personalised medicine. And the most important word in this discussion then is context. I really recommend the work of Vina and Schwartz. They published a book called Listening for What Matters, and there are papers on the same sort of thing about contextual errors in medicine. And that is where the evidence-based recommendation is not right for this person, where the context is different. And we know that the trials are done in populations. You can guarantee there's no Aboriginal people in those trials. Maybe does that matter? Is it different? Well, we don't know. But context does matter in clinical decision making. So the research evidence is important, but the context is also important. We talked about geriatric oncology as an example of a vulnerable population. Well, just about all our patients are a vulnerable population, and require some personalisation of the recommendations that's made. One of my favourite examples is for HCC, which is tomorrow's dinner. But if you've got MDT recommendation for someone with multifocal HCC that's progressed after local therapy, you could give them atezo-bev, or you could give them lenvatinib. But the atezo-bev means that they'll have to travel 8 hours on the bus to get to see us every 2 weeks, for more or less for the rest of their life. The lenvatinib is an oral therapy that can be supervised in the community. So that context matters. Now, often in the MDT, a lot of the information, some of this information might not be brought to the forefront of the conversation. We've noticed that there's a big difference whether we participate in the MDT or not, because the answers you get back from MDT, if we're not there, might be answers to questions that are different to the questions that matter to the team that are looking after them. But of course, being involved in MDT is a challenge, because there's only one of me and all my colleagues next week. There are 12 MDTs to go to. So the assistance in getting to be able to participate in that, and thoughtfulness like putting them on the front of the thing so that we can dip in and dip out, etc. But understanding those contextual things is important. One experience that I think changed my oncological life was going out on a home visit with a palliative care team. We saw a patient in Tennant Creek that we were thinking about giving chemotherapy to. Now, I don't know about your social history or your history taking, but for me, I thought this was a reasonable thing. When I did the home visit with the palliative care team, I realised this patient lived in a caravan, and the caravan was 100 metres from the toilet. And we were about to give him diarrhoea. Now that was critical sort of thing for the impact of this of the treatment on this man. That's something about the context that we don't usually understand. The patient preference, of course, is another part of the of context. And for that patient with the HCC that has a choice in between having coming to Alice Springs to have their treatment or staying on community, then for some of those patients, the improvement in a small increase in survival will be really important. But for some patients, staying on community is going to be really important. So how do we have that conversation? How do we understand and how do we include the patient preferences into our decision making? And of course, the clinical state is another aspect. Half our patients have diabetes, often poorly controlled. They're often this far away from having neuropathy before I start the oxaliplatin. We have the highest end-stage renal failure and dialysis rate in the country. These comorbidities and other illnesses again need to be brought to the front of the discussion in the making a decision. Now, we deal with this in MDTs normally by the fact that we acknowledge that the MDT recommendations are recommendation. You've got to see the patient, you've got to put it in context, you've got to... but it's true that these MDT recommendations have a sort of normative force. If they come back from Adelaide with a recommendation they have chemotherapy, that can take some backpedalling, etc., if you don't feel that that's the appropriate thing, or if that's not in accordance with the patient's wishes. So our approach to this is what we would call a bespoke MDT. Thank you, Kevin McLeod. It is about the MDT we normally go to is the same group of people every week, sitting around the table. This is bringing the individual people that are involved in this patient's care into the one room so that we can make a contextualised decision. And of course, the patient and the family get a chance to say what they want. It's not practical for us to involve patients in our general MDTs. We'd never get through the list that we have, but it does seem like an omission. And this is a way of perhaps trying to do that. The primary care really has a big part in bringing that information about the context to the table. Unfortunately, in the city, it's becoming a little bit of a pipe dream that you had a GP that looked after you since you were a baby, and that they know the whole family, and they etc. That's not the way modern care works as much. And here we've got problems with continuity of care, etc. The high turnover of staff, etc. but the GPs who have been in community for a long time are an invaluable resource about contextual information, and they do know the family, they do understand the environment, and we need to bring them into the conversation. Including the Aboriginal liaison officers, etc., is another stakeholder and aid to communication. And it may be that we need to bring in the generalist or the renal physician or whoever it is, else into this bespoke MDT. Now, this is the sort of model of shared decision making and a shared care, really. And one of the difficult things for us is that we bring people back to Alice Springs, we give them poisonous drugs, they're all right when we see them, and then we send them back into the community. It makes sense that we need to do better at including the clinic and the local community in the care. Shared care, I think, is going to be an even more important thing as the technology improves and our reliance on the cancer centre becomes less important. Cancer centres, from an oncology point of view, chemotherapy point of view, were invented because you can't give cytotoxic drugs just anywhere. But we don't give as many cytotoxic drugs as we used to. We're giving immunotherapy, we're giving targeted therapy. The NHS just approved immunotherapy as a subcutaneous injection. So our capacity to deliver targeted therapies in the community is only going to get better. Of course, a lot of the issues around multidisciplinary care do relate to the social determinants of health. Our palliative care team have spent a long time trying to get a man an air conditioner who lives in a shed where it's 46 degrees. And it's just, having a place to live that's safe is a really key part of access to care. It's going to make more difference than the chemo does for most of our palliative patients. Improving health access and quality, etc., education, economic stability, and understanding that context. So these are all things that play out in the delivery of multidisciplinary care. And they're also things that I would encourage all of us to advocate for and to act as the advocates for these issues that really determine so much of what happens. Now, one of the things that our patients find really difficult is navigating their way through the system. And this is a slide from the South Australian Cancer Navigator Framework, excellent document. But it's just highlighting, I think, that people need help navigating their way through the system. I need help navigating my way through the system. One of the key things, I think, for us is to know who to call. And when you talk to people in primary care, one of the things they want is to know who to call. So making the system easier to navigate and providing resources like cancer navigators and care coordinators, etc., that help people navigate through the system is again critical. So to summarise, multidisciplinary care in the outback is different. Our access to centralised MDTs is critical and really appreciated. Contextualising care through bespoke MDTs is something that we need to be able to do. And this requires a different idea of telehealth than what we have done before. It's not just dialling into the clinic and having a nurse. It takes some work to make sure all the right people are in the room. Issues of access to care and cancer navigation are dominant. And doing all of this requires a different skill set. We need to learn how to contextualise care. We need to learn better communication. We need to learn a slightly different emphasis on skills than we do in the in-city practice, and your skills will make a difference. So I also would put a plug in for people to send their trainees to be to have people learn how to learn these skills. You'll come back to your city practice as a better practitioner, or you might come and stay with us. But spending some time learning these is a fabulous thing for everybody. So thank you for your attention.
Thank you, Matthew. And I'll invite our last speaker, Christine Sanderson, who's the Director of Palliative Care here in Alice Springs Hospital. So thank you, Christine.
Thank you very much for the opportunity to present tonight, and it's lovely to be here with everybody. And I too want to acknowledge the great privilege and joy of working on Aranda country, unceded Aranda land, and being able to look after the people of this community from all the various places they come from. This is a picture from one of the ceremonies we have in palliative care regularly, to a cleansing ceremony to keep the place culturally safe for people to use. It's a support that's provided to us by the ladies of Akilera, which is the Aranda Healing Centre in town. So every specialty has its procedure. This is our procedure. We use the retrospectoscope. Matt, it's a very expensive implement, needs a bit of maintenance. But I guess the privilege of palliative care when we sit down with patients is we get to really reflect on the whole journey they've been through with them. And often we're learning a lot about what they've gone through, the bits of the system that work for them and don't work for them, the missed opportunities, the sadness around that. And that's a lot of the stories we're hearing in palliative care all the time, and there's a lot of learning opportunities for us. And when I first came here about 6 or 7 years ago now, just pre-COVID, around about the time of COVID, there was a case I remember that taught me about all of these things. So a gentleman, probably in his early 60s, was sent in by his clinic with a palpable liver mass. It was COVID time, our hospital was not functioning at its best, lots of things were a bit crazy. He came into ED, was scanned, and he did indeed have something that looked like a nasty malignancy. It was probably midnight by the time all that had been done. He was by himself. I think other people weren't allowed to be with him because of the rules in the hospital at the time. He was hiding under the blanket. He was documented as being not communicative. And the basic tests, investigations were done. We didn't have an interventionist available for a while, so the message he was given was, come back in 2 weeks and we'll do a biopsy. His son picked him up the next day. That was communicated to him by a nurse. The message the family heard and received was that they were being kicked out, but to come back in 2 weeks, and then he might be able to go back to Adelaide. So never a proper conversation. He went back to that community, put himself to bed. The family were ropeable, furious, thinking he'd really been kicked out of the hospital. He died within 10 days, basically deteriorating incredibly rapidly. Clinic were beside themselves. There was so much hostility and distress from the family. The clinic literally couldn't get in to help assess him. So he really had unmanaged pain and symptoms. It was a very, very distressing case, in fact, and he never got his biopsy. For me, there's a lot of lessons in that story. It's one of a lot of stories we see of delayed diagnosis, miscommunication, messages that don't get through, and then, the sad outcomes for people. We see a lot of what happens when we don't consent people well, when they don't understand what it is they're going to go through, when we transfer people with the best intentions to get the best care somewhere else, but they're by themselves, they don't have anyone they can talk with, they don't really understand where they're going. It's a very frightening process for them, and it can go badly wrong. So I'm going to, pick up a lot of the themes that we've heard tonight. I won't be too long, but and echoing a lot of what Matthew said, who's a great partner in crime in Alice Springs Hospital these days. Thank you. make this thing work. Right, so I think the reasons for delayed diagnosis are kind of obvious when you look at a map, but if you actually have the experience of going out of town and going to clinics, seeing the distances involved, the logistics involved, the practicalities, you know, the places where there's just no mobile phone coverage, you know, the logistics are just, you know, they're a wonderful challenge all the time, every day. But there's also the other thing that we see with clinics and in people's lives are the competing priorities. There is a lot going on for people. So, you know, we ring the clinic and they're so busy because they've got a TB case and a car rollover and a couple of preemie babies they're trying to retrieve, and, you know, you get a couple of minutes with a doctor to have a chat about the patient you're worried about. There's a lot going on. So getting things to the top of people's list is hard. And then the process is incredibly complicated and arduous for people, sometimes involving multiple stops. You know, some people might go from Kintore, which is over on the near the Western Australian border, to Tennant Creek to here before they get their CT scan or whatever. And there are long distances and a lot of different people involved in that. And in that process, they're separated from their family. And I guess when people do arrive, and they are, you know, obviously with an advanced cancer, then there is the question of, you know, what should we offer to this person now? And we feel bad. Everyone feels bad. People are upset. People are angry. It's like, okay, you know, have you missed the boat? Is it too late? How should we make those decisions? And how do we deal with the fact that there's a lot of grief, a lot of guilt? We feel bad, you know, when someone comes with a really late diagnosis. We really would like to do our best to give them something. And I sometimes think we don't make great decisions actually in that context. So there's a lot of cumulative trauma that I see in relation to some of these diagnostic processes and the doctors making these decisions and trying to get the best outcome for people. And I'm sure my primary care colleagues might have some stories around some of this stuff too. So I have as much input as I can within the hospital, in M&Ms and, you know, in relation to the handovers and the planning care for these patients, to try and encourage doctors to hasten slowly. Exactly what Matthew said, we need to take a lot of things into account before we stick people in a plane and send them somewhere else. When they have an advanced cancer, you know, we usually have the luxury to have a bit of a think about what it is. But if they've got an obstruction, or they need an ERCP, whatever it is, we should still have a think. Is this person actually going to survive the trip, is my first question. If they're not going to survive the trip, it's a really, really difficult thing to stick them on a plane and send them somewhere else. That needs a very particular kind of conversation if there's a risk of that. If people accept the risk and it's, you know, it's felt to be worthwhile to give it a go, absolutely fine, but they need to understand, because we get many patients who don't make it back, and we get patients who come back bloody nearly dead and they come straight to palliative care and they've been through a pretty rough time, you know, before they come back to us, and it's not what they expected and it's not what their families expected. And then we get a small number of patients pretty regularly who come back ventilated to pass away back in Alice Springs, you know, which is tough. So, important question to ask. Question number one, will they survive? And we do send some people who won't, and we shouldn't. And then the next question is, well, will they get some treatment after this, like some meaningful treatment that's actually of benefit to them? Is that something that's really on offer? Because if it isn't, we shouldn't get too excited about promoting the whole get on a plane and go to Adelaide story. It doesn't mean we don't offer it. People need answers, people need information, that's fine, but it's a different kind of emergency, you know, when it's just answering a question, as distinct from offering a life-saving treatment. Have a think before you act. And do they and do we understand the risks and the benefits of whatever's going to happen to them at the other end? But finally, how does this person need to make decisions? And I'm talking very specifically, I guess, about a lot of our Aboriginal patients here, our First Nations patients. for whom decision making is not an individual autonomy kind of concept. It's actually very much about a family process of how decisions happen. The right people need to be in the room. They all need to hear the story. People need to have a think about it. There's a whole spectrum of ways it can happen, but that is the default for many, many people. And we send someone at 3 in the morning or put them on the early plane. They're in Adelaide at 9 or 10 by themselves. They don't speak language. There's no one there who can speak their language back to them. And they don't have anyone there to support them. And it's not just psychosocial support, it's actually decision-making support. To my mind, often I see people where I think the consent has been really, really poorly done. It feels like it's been done well at the other end. We've said everything we need to say, but it hasn't got through and the right people have not been involved in the conversation. And when they come back, we're picking up the pieces of trying to tell the story again so that everyone knows what happened, why it happened, that it was okay. Things were done as well as they could be, whatever it was. And there's often a lot more story to kind of sort out at that time. So those issues in consent are very, very important and very difficult. And I think one of the things about a bespoke MDT, one of the things about an MDT where we're perhaps stepping people through the process in advance, thinking about what they're likely to have to go through, is to maybe pre-consent them here before they go. So have some of those conversations in a different way, a different setting with the right people in the room. Because it's very, very hard at the other end, I can well imagine. And what I've learned here about cultural safety is the most important part of cultural safety really is family. So having family, I get a lot of things wrong, but and I'm learning all the time. But for me, if I'm engaging family, I've got family there, I'm talking and listening to them, I make sure I'm asking who the right people to be there, are they there? Then I've got my best chance of providing culturally safe care and not really stuffing things up badly for people. Collaborative decisions are much better decisions in all of these situations, and having palliative care in the mix, and we like to get in upstream, and I'm a bit I get stuck right in if I get the opportunity. We can contribute a lot to the sort of decision making that I think helps. So we like an early referral, though sometimes that is challenging in its own right, but we can, in our assessment, we are looking at people's performance state, at their symptoms. We can, as we track people along who maybe, as we walk alongside them when they're having cancer treatment, someone with an advanced cancer who's been referred to us, we often will be able to see how they're going with adverse effects. People step up and put their best clothes on when they go into oncology to see the consultant. But, we see them at home and down the shops and hear from their daughter or their son or whatever. We know whether they're tracking okay or not. So performance state, all those things that are really crucial to good quality decision making, and the family stuff that might be going on around that person that can make things very, very difficult, or equally is a strength that will help them get through if we can just pull it all together, help them harness all of the support and love that's around for them. And anything else, and there's always a lot that can affect people's ability to get through their treatment. So when we're talking collaboration, who needs to be involved? I really strongly argue for pulling in the clinicians who know people best. So the remote clinics should be on the phone, the GPs should be on the phone, the ALOs and cultural brokers and the family. So it's a big tent. So we are there to support a lot of patients through their palliative treatment. So here in Alice Springs, we have the capacity to do that and to really be there and work very closely with our cancer team here. So we do see a lot of patients with GI cancers, and we try very hard to make a good plan up front, and that makes a lot of difference, and communicate that well. And then safety netting patients as they're being treated. It may not be us that's, it's not always us that's visiting people at home. It might be our colleagues in Congress or their GP or the community nurses or other community services that we are aware of that are involved. But we try and put a good safety net around people so we can see what's happening for them and make sure they're travelling okay, and that they're quality of life and their, the things that matter most to them can be addressed. We have the capacity to admit people to the palliative care facility, the comfort house, if needed, sometimes during treatment. So at the moment we have a young chap, it's not a GI cancer, but he's got an awful head and neck cancer, very malodorous, stigmatising, horrible lesion. And he'll probably come and stay with us when he has his treatment now, which is much better for him than going to the motel where he was going before. And we can manage his wound and give him some support and check him out and make sure he gets to his treatment, keep him on track. Build up a good relationship with him for the time when the wheels fall off, which is, very foreseeable. But that improves things a lot for him. So, we can help people actually get the treatment they need and get through it in a way that's more manageable. We will often, if people are happy and they want us there, we'll attend an appointment with them if there's no family around. And that allows us to have a better conversation about what's happening for them. We can, sometimes just things flow well if it's a three-way rather than just a one-on-one appointment. And in that way, we facilitate relationships with the oncologist. So we're supporting the cancer doctors. The cancer doctors are doing a good job looking after this. This is how the treatment's meant to work. What things are you worried about? Let's make sure they know. Let's check in about that. And likewise, the cancer doctors support the patient's relationship with us, because often palliative care is like, no, I don't want to see those guys. I'm not dying yet. Well, true. But if we're brought into the mix positively and helpfully early on, we're there to really support people through. And then at the time when they need us, coming towards end of life, the relationship's a very different one. It's not like they're being, dumped and handed on to someone else because we can't do anything else for you. So that's the way we try and do it here, and we're blessed with it really with the resources and relationships in this small town to have the opportunity to do it pretty well at times, though it can be challenging. What could make a real difference for our patients? A safe place to stay. Accommodation in this town, is difficult. I don't know what's wrong with this button. Having somewhere safe to stay is incredibly important for people with cancer who are going through treatment. So people come to town regularly from great distances and stay in amazingly awful places at time while they're having their treatment. I remember doing a family visit for one lady who really wasn't doing well, and I found her out about this time of year, so it was cold. She was sleeping out on the ground under a minky blanket. She was tucked in. She'd had cytotoxic treatment the day before, so in hospital it would be all purple gloves and hands off, but she was tucked in under the blanket with three little toddlers and a couple of dogs. And she was not looking great either. But, somewhere safe to be. We don't have purpose-designed accommodation for cancer patients here. The Aboriginal hostels where people stay are often shared rooms with no en-suites. So people doing bowel prep in an environment that's not fantastic, for example, or going to have diarrhoea or whatever it is. So we've got some work to do there. And then at a certain point, things come to the end. Treatment stops, or the person can't have it anymore for some reason. They're coming to the end of that cancer story. And obviously this is normally where palliative care steps in most places. And we really want to help them finish that story properly, and that's whatever it means to them. And the better our relationship is with them through the whole process, the better we can make it happen for them at the end of the road. So our earlier involvement really, I think, supports people. It takes time, but I guess our other skill is to try and, make a relationship quickly when we have to, connect with people well. We really do appreciate early referrals, but sometimes it is also very hard to walk alongside people for a long time. Cancer treatment, people are really challenging my fatalism these days, and people are living for a long time. And so, sometimes it's harder for us to predict, where we're going to be useful and how long we're going to have to be part of their lives. But we manage that as best we can and juggle our small but effective resources to make that work. And what we really want is for people to have choices at the end of their life. And we talk and think a lot about returning to country. That can be wonderful. It can also be incredibly challenging. There's a lot of logistics and practicalities that make it quite hard, including, for example, in some places where if someone dies in a house, no one else could live in that house for, you know, many months, sometimes even years. That still happens in some places. It's not as common as it used to be. But it is a bit of a disincentive to looking after someone in your home to know you can't be there for another couple of years. And a whole lot of other cultural things that are really challenging. There are some kinds of deaths that I try and avoid keeping people in the community if I've got a way to plan it. For example, people I know, you know, with a bowel obstruction or with a big bleeding risk, because I think they're pretty traumatic and difficult in the community. But that said, we do and can help clinics to manage those sometimes. And we have to work really, really closely with our remote colleagues. But there are other choices. We have a beautiful inpatient unit here in town now, and that's a really acceptable option for many families. And a lot of people in hospital, having everyone come into hospital because there's been some event, and then everyone's come for the family meetings, everyone's here anyway. And, you know, they come into the palliative care unit, they say, no, stay here, this is okay, this is good. So I think, you know, the care there is acceptable and welcome by many people, and sometimes that is a place where people choose to be. It may not be, you know, there are many compromises involved, I guess, when you're dying. And some people don't want to come anywhere near us and can't get home and they die in hospital, and we can support them there. But, you know, it's all about choices, so having some choices is the aim of the game here. So this is our sort of logo. It's what we try and do. As I said, family is incredibly important. And I invite anyone who wants to come and visit us to come and have a look at our facility. You're welcome to check out what we do and where we are. And I appreciate all of you coming to visit us in Alice Springs, those of you who are from far away.
Okay, to sit up here. Can I invite all the speakers to please come up, and people online, if you have questions, please put them in the chat or wherever so that we can get to them. People in the audience, we've got a roving mic somewhere, or a couple of mics, so if you've got questions, please put up your hand and ask the panel some questions. While people are thinking about things, maybe there's some nice questions up front. There we go, okay. Please.
Sorry, hi again. I'm just going to talk to a few people, probably not Xavier from the surgical approach, though. Just looking at the remote sort of stuff. So I think, and with Alex as well. So interesting from your slides that you're sort of indicating in Indigenous people that there might be sort of a younger population that is outside of the National Bowel Screening Program. So I guess just to paint the picture from a remote perspective, so classically some very dedicated RAN will do some blood tests, will do some iron studies, and we end up with very high ferritins in most people because there's usually a chronic inflammatory process going on for their diabetes or whatever, a low transferrin and a low MCV. Could be a postmenopausal woman where we sort of start thinking along this line, but if we've got a 35-year-old, as you were sort of saying with your data, most of the time I think as RMPs we're probably going down the menorrhagia exploration route first before we would ever think of sort of bowel problems. Some people might do strongyloides serology, but we'll pretty much always get an IgG positive, so what do we do with that? Do we send off FOBs? Again, the National Screening Program won't hear about them because they're going to Western's pathology. We might talk about menorrhagia. Again, it's a new concept to a lot of women, so you're just trying to work out what's normal for them, what's not normal for them. And I think anecdotally we'd all agree, certainly any newly pregnant person seems to drop their iron very readily. So again, I don't know what the iron stores in Central. I've worked in Top End and Central, and Central very much is, you have that very early iron deficiency in pregnancy that I have not seen when I was working in Top End. So again, whatever the cause of that is, some people might argue it's nutrition, others might argue that it's the chelating agents in the bore water that people are drinking, or who knows. I don't know that there's science behind it, but it's just a real, I guess, a where do you start? Again, hopefully not ending up on Xavier's doorstep, but in terms of blood tests, bowel screening, and where do you sort of, I guess, we're trying to be comfortable in our own city. We've investigated everything that we should, but yeah, I guess from what you were sort of saying is that this is a newly emerging data in that, and that we could have a higher incidence of bowel problems in this age group. It's kind of, I guess, from our point of view, sort of where do we go? And then confounding all that is the challenges, which I think has been mentioned a few times with remote. For example, some people don't get a bush bus, which is the only transport available. I know, and I'm probably dobbing Matt in here, but I sent someone in with a HB of 80, a 60-something-year-old man who unfortunately was discharged a couple of days before he got his scopes. Mistakes happen and they apologised. But it's a month later and we still haven't got any communication. There's no phone coverage other than the shop where he lives, and he's 4 hours drive from Alice Springs, and we've been cut off for 3 weeks from a weather event, even trying to get up there to find him. So lots and lots of challenges, but still a wonderfully positive place to work and lovely positive people that we work with. But just giving that as a couple of examples of how do we approach, particularly, you know, that which we see very often is that low MCV, that low transferrin, the ferritin that's useless to us. Where do we start, I guess?
An unenviable position, I must admit. I mean, you're quite right that the challenges are extreme. In that sort of context, we've got the same sort of issues. I mean, in premenopausal women that are iron deficient or have iron deficiency, it is certainly a concern. I don't know that I'm going to give you an answer, but fecal occult blood testing, I mean, as a way of triage, you know, potentially, because it's simple and you could do it, and you might be able to do it in rooms or whatever, and so get a response. Sure, it's not going to be part of the National Bowel Cancer Screening Program, but nothing under 45 now is actually going to be recorded anyway. So irrespective of that, for a clinical decision that you need to actually make there, I was fascinated with that data. It came out of Queensland. It's an NHMRC funded researcher that's actually led that sort of work. I'm almost not believing it, because it's actually antithetical to everything that we've actually heard. But it's there. They've got the numbers, so they've actually, so they must be real, which is a bit worrying, because it seems like something different is actually happening in those communities, and whether there is a cultural thing, they're not coming forward, they might have symptoms, they might be described like you describe, and so that they don't really get diagnosed until late or whatever. It's hard to know, but trying to keep pragmatic and keep the simple things, as you guys do really well anyway, and trying to do things like FIT. So the NHS is actually doing this to try and triage colonoscopy, because they've got such waiting lists that they're using fecal occult blood tests, even in young patients, to actually try and differentiate them, to actually say, well, okay, they've got an FIT positive, it might be IBD, you know, more likely IBD than anything else. And so they triage them towards colonoscopy that way. Of course, you've got the added problem of, okay, if they need a colonoscopy, where are they going to get it done? And that's the other challenge. And Richard and I have been speaking about this as we have with other administrators in NT Health and beyond, to actually see whether we can actually deliver accessible care in a functional way out in the community a little bit more, because getting into Alice, as you say, is a challenge, but Alice has got their own challenges with the wait lists that they've actually got and access to theatres as well. So lots of things that I'm not sure that I'm going to have an answer. I'll open it up to the floor if you guys have any ideas on how to address these issues by anybody. Kirsty, anyone? Sneha?
I think one, it's great that you can, you have this data on the patients, you've got their MCV, you've got their iron studies. I would agree that the iron studies can sometimes be completely useless and unhelpful, and it probably represents dual pathology, so an underlying inflammatory condition in the setting of established iron deficiency. I see a lot of young women who are essentially iron deficient from the age of about 12, and they're just on and off oral iron supplementation for their entire reproductive life, with several missed opportunities to ensure that they're adequately iron replete. So I think menstruation aside and reproductive losses aside, it's not unreasonable to investigate these women. Fecal occult blood test definitely does have its advantages and can be useful in risk stratifying these patients, but what I'm seeing in my practice in this cohort of young women is that they've got these very flat lesions in the proximal colon that don't bleed as frequently as the traditional tubular adenomas, and so these are being missed by fecal occult blood testing. And I've got a cohort of these that their GPs are insisting that they have colonoscopies, and they're like, oh, it's just because I've had 3 babies and breastfed. But when I go in, there's advanced lesions there, and these women may not have been detected if it wasn't for their GP insisting that they have a colonoscopy, even despite negative fecal occult blood testing. So I think thinking about it as an issue, discussing it with the patient, and providing them with the options for further investigation, I think is definitely helpful. And then also addressing menorrhagia if you feel that that is a problem, so that we can reduce that.
Thanks, Kirsty. Before I go on, there's someone on the screen that I've neglected, as a bad chair that I am, to actually introduce Sharon Carey, who's the current AusPen president and basically head of or managing nutrition services at Royal Prince Alfred. Royal Prince Alfred, yeah?
Yeah.
Yes. So
Thanks, Alex.
Welcome, Sharon, and thank you for being a guest participant on our panel as well. So I'm sure the questions will be coming. I think I had another. We'll take Daniel and then back to the front.
Actually, my question was actually for Sharon. Actually, we heard a little about...
there you go, Sharon.
We heard... hi, Sharon, Daniel here. We heard about food security tonight in one of the talks, and as a dietitian, if you're managing someone with colorectal cancer or trying to prehab them for surgery, how do you tackle food security but also manage their nutritional needs as well, given their GI diseases?
Yeah, thanks, Daniel. It was really interesting to hear the presentations, and I was thinking, we did hear a lot from the medical and surgical teams, but behind them all is obviously, hopefully, a team of nurses and allied health staff who can bring a lot and support patients through their journeys as well. And as Daniel said, prehabilitation is a really big thing now. The evidence is really strong to have better outcomes after surgery if we provide support for physiotherapy and nutrition and psychology. I guess the question is, and it's a really valid question, Daniel, is how do we make sure that people in rural areas have access to this sort of care, and how do we make it culturally appropriate for them? And I'm not sure that we've got the answers yet, but I know that at Royal Prince Alfred we're doing some work with looking at the how to make prehab culturally appropriate for the Aboriginal population. So I think that there's still a lot of work to be done in that area, but I think making sure that people get access to the best possible care, including allied health and nursing, is important.
Thanks, Sharon. Thanks for your input. We had a question up the front.
Hi, quick question, just for the first two speakers, following up from what Paula was saying. Any feasibility of point of care FIT, either overseas or done here, to get over refrigeration, other issues like that, and would it be acceptable for follow-up?
Good question. Haven't seen anything. Haven't seen anything available in that sort of tech. You know, they're moving more away from immunochemical tests for hemoglobin into these DNA-based tests that they're even worse. They need a specific laboratory to actually get that done. So no, but I mean, the actual assay is not very hard to actually do, but there's nothing in the literature that I've seen about point of care, unfortunately. Would be a good idea, though. Oh, yep.
Question about the MDT. I just wonder if, I think telehealth has made an enormous difference since COVID, and I've seen it done very well with some bit of preparation. A person with advanced cancer who had a oncologist and a surgeon from Adelaide speaking to a group of family of 8 with an Aboriginal clinic manager and the RMP in the room, and it was bespoke, but it was also high level with questions prepared, and it worked amazingly well. And I just sort of offer that as, you know, it can be done. And I'll just say that in Central Australia, in the NT health clinics, in the remote clinics, we are fully staffed with rural generalists, and I think that's quite exceptional given it's the remoteness, and it's kind of worth people knowing that. And we mostly have a male and a female GP at each clinic, alternative weeks, so yeah.
And so, sorry, can I just ask, do you participate in MDTs using Zoom or Teams or anything?
On that occasion, I was the RMP, but
Right.
often I'm not asked.
Would it be, I mean, it sounds like, Matthew, I mean, maybe you can comment here, but I saw GP being there, or, you know, primary care physician. Would that be valuable? I personally think it would be. Matthew?
And often if the cancer is, as it quite often is, advanced, it will be really good to have Christine or one of her team in the MDT as well. I think that's really helpful for sort of wraparound care.
So, Matthew, is there concerted effort to actually have this? And maybe Christine, if either of you can talk to that. And I don't know what your experience is, Xavier, because I'm sure you join these MDTs as well.
I'm making a concerted effort, but I think the barriers are very significant. It's been one of the things. It takes continuity to sort of understand all this. And I think when I was flying in and flying out, it took me a long time for the penny to drop that this was the case. And when we've got a different person every week, it's not, you know, it's not working. And it's logistically a huge challenge to get all the right people in the room. We have high DNA rates and all that sort of stuff. It's taken me a long time to realise that I have to ask what day the GP is there and not just book the patient in for when it suits me. So there's a lot of learning that's required to make it work, and we've got a long way to go for it to become a standard, but it's definitely the way that we need to go.
Okay. Any other questions? Was there? Oh yeah, sorry.
Thanks everyone. I've got a question around colorectal cancer and rectal cancer in particular. Are we seeing any reduction in incidence with HPV treatments, in particular with our Indigenous cohort, knowing that head and neck and rectal cancer is related to HPV-SCC?
No.
Yeah, I'd second that.
HPV's got nothing to do with rectal cancer. It's an adenocarcinoma. It's biologically a distinct entity. Anal SCC, I'm not sure if we're seeing reduction.
Yeah.
I suspect we would. It would make sense if we did.
Correct. So the SCCs, the anal SCCs, will be much more related to that. One thing that's of interest is those early onset colorectal cancers tend to be predominantly rectal. So in the younger community, there are a lot more rectal cancers that are actually developing. Again, we don't really know why, whether this is the red meat, epidemic that we're actually seeing, because there have been associations with red meat and rectal cancer, but it's an observation that's being seen quite a lot, and obviously with disastrous consequences, given all the surgery and things with the rectum. Okay.
Sorry, but have we actually seen a reduction in anal SEC with HPV?
I haven't seen it yet.
I haven't seen any data on that, but it would make sense that it would.
Yeah, it would, if it's going to be anything, it would be that. Yeah. I don't see any other questions from the audience. Is there any online? No? Okay. Well, look, it remains for me to thank all our speakers, which has been fantastic and thought-provoking. We've gone from screening all the way through to palliative care, and so I think we've covered every topic that's material. And I mean, the resounding theme is the challenges that you guys here in rural and remote communities tend to face, and I think making a concerted effort to try and solve them would be, beneficial for all. We've seen the statistics that are not great in terms of, remoteness actually causes more problems in terms of, one, identification, but then also the management of that, with all the different complexities that are there. And so I think putting a brains trust together and hopefully lobbying more for funding that will actually help deliver from all the gamuts that we've actually seen, including screening as well as palliative care. We need obviously accommodation, it sounds like. That is a fundamental thing that is required there. And so I think there's lots for us to do in this space, and please put your hands together for the panel. It remains for me to thank our sponsors yet again and our partners for contributing to this. Our sponsors are Olympus, Boston Scientific, Pfizer, GSK and CSL. Thank you again for putting up the money to actually help us deliver these sorts of learning environments, which I find very fruitful. And with that, I'll close the meeting. So thank you very much.